We shall now proceed with the second day of this CME. It's our immense pleasure to invite eminent Professor Dr. R.K. Sharma sir to deliver his talk on the transplantation and nephrologist journey. To chair the session, may I invite the chairpersons, Dr. Anish Srivastav, Professor and HOD Urology, SGPGMS, Lucknow, Dr. Jitendra Kumar, Senior Consultant Nephrology, uh, Heart Institute and Multispecialty, Faridabad, and Dr. Damen Badoria, sir, Additional Professor, Department of Nephrology, SCPGIMS.
Good morning, everybody. And this is my proud privilege to request Professor R.K. Sharma, who's my teacher, mentor, everything, to teach us again. Over to Dr. R.K. Sharma.
Good morning, ladies and gentlemen. Thank you for giving me this opportunity. I'm going to tell some stories about a kidney transplantation. This is the start of my journey. After doing my post-graduation in medicine from Maulana Medical College, I shifted to All India Institute of Medical Sciences, New Delhi. And this is the, at that time it used to be called Old Operation Theatre. And adjoining this building was gastroenterology, Professor B.N. Chandran, some of you might have heard. His office was next to this building. So here was the nephrology department. It has moved since then. And these are the teachers and mentors and some of my colleagues. Dr. Rana was 1 year senior to me, and he later on went to Gangaram. And Professor Malhotra was actually instrumental to bring me in nephrology because I wanted to become a cardiologist and was working in Jeevbant Hospital when they had shortage of residents because the senior registrar had moved to Gwalior to look after one of the very famous temple priests there who was on dialysis. Why I'm telling you this story is that when we were in training in All India Institute, the immunosuppression was azathioprine, mainly azathioprine based, with heavy steroids, steroid toxicity, seeing a lot of infections related to heavy immunosuppression. But some of the longest surviving patients we saw were actually on azathioprine. And one of the patients whom I was involved as a registrar in 1979, Mohammedan patient from a lower socioeconomic background, Paul Delhi, he is still surviving for almost 45 years and is only on azathioprine based immunosuppression without any rejection. And he had some comorbidities also, being a diabetic, and he has undergone cardiac intervention also. This is one of the studies published in our Indian Journal of Transplantation, which has tried to conclude that AZA-based immunosuppression has almost equal outcome as compared to MMF. But if you carefully look at it, you will find that the graft survival is 65% and 75% at 5 years. A graft survival which is 10% difference. If the number of patients was 2,000, 5,000, or 10,000, even a 5% difference in the graft survival will tell you that it's a very significant difference. But this study, being a small study, a retrospective study, this difference was not found significant. So was the conclusion. I'm not saying that azathioprine is not good, but I'm telling you the fallacy of the study, number of patients which are there, that the study is randomized or not. So those things we have to keep in mind. This is another study, Italian study published last year, which is also not having too many patients, but done in a randomized manner where they have shown that even in deceased donor kidney transplant, recipients who are on low dose cyclosporine and steroids, MMF had no significant benefit over AZA, suggesting that even in deceased donor transplant, you can get away using azathioprine and cyclosporine. These patients actually had induction protocol, which is now universally used, basiliximab or hemoglobin. I just showed these two studies to show you that studies, the way they are done, the way conclusions are arrived at, based on the statistics which we apply, can sometimes may not be powered to reach to that sort of conclusion. This is a cartoon painting made by Sir Roy Khan, which shows you what happened in December 1954 when the first successful kidney transplant was done. And this 15 years later brought a Nobel Prize, which is shared with the bone marrow transplant. This was a transplant done amongst actually identical twins without any immunosuppression. Azathioprine came even later. But this patient, despite being actually identical, survived not more than 8 years. So you have to understand that immunosuppression is quite important. David Hume, you might have heard, he was a member of the team which did the transplant in Boston, and Joe Murray got Nobel Prize for it. He was a multifaceted person, and he had an early death because he was he was a pilot, a professionally trained pilot, and despite being warned that the weather is not good, he was flying a plane all alone and had an accident and had a premature death. But the first paper in transplantation was actually published by him. He was a great researcher and had a lot of funds available. And after his death in Virginia, they used those funds by the time Medicare had come to make the basic research HLA lab, a lab for, they called it ALG lab, and also for vascular lab there by the funds which were left. The Peter Medawar is called father of transplantation biology. Both these paintings are done by Sir Roy Khan. My story for continuing in transplantation interest from All India Institute went to Ahmedabad. And in Ahmedabad, it was rather a coincidence because we never used to say no to our mentors. And Professor Trivedi, who had started nephrology department in a small setup in BJ Medical College, and later on you can see now there is a big institute by his name, which is doing large number of transplantations. So he almost forced me because he wanted to start an HLA lab. So he forced me to go to University of Alberta, a Canadian Center of Nephrology and Immunology, and you can see John Dossiter there, who was the chairman, who later on migrated into bioethics. And there is an institution by his name in Edmonton on bioethics, and he has written his memoirs. And why I'm highlighting the part which he has written in this book, that he's acknowledging his relationship with the students and mentors. Some of the names which are mentioned here, when I was there for training, they were actually senior professors. So he had mentored them in McGill University. And then in Edmonton, Johnny and other Indians, a lot of Indians went to Edmonton and were mentored by him. This is one of the senior technicians, Joyce Shroud there. In SCPGI, we started the lab in 2010. It was an opportunity that at that time, the institution provided a good infrastructure for doing all basic immunological workup, which was available and could be done in-house, including flow cytometer and the Luminex platform, and also the HistoSpot, which is an automated robotic instrument for doing HLA typing, and now even you can do antibody assays in it. Now I moved to Medanta, Lucknow, where we have done about 100 transplants, and about 20% of them are ABO incompatible. The oldest donor which was used is 71 years of age, and with reasonable, acceptable outcome, and also started a transplant lab there. These are some of the photographs of our donors in Vedanta. The two people who really helped when I was in STPGI one was the International Society of Nephrology funding for training, and Praveer Roy Chaudhary and Alan Gurnika. They have now moved from Cincinnati. So they were helpful to get this ISN apprenticeship program for training in transplant immunology in Cincinnati. In SCPGI, more than 3,000 transplants experience was there, and we have had reasonably satisfactory, comparable transplant graft survival for up to 10 and 15 years, and also the patient survival. The interesting thing is that as the transplantation evolved, even early 2000s, MMF had totally taken over azathioprine. Use of azathioprine has disappeared by the 2003, and tacrolimus also replaced cyclosporine by that time. And this has happened. This is US RDS data, even USA. Some of the publications which were in the area of ABO incompatible transplant and sensitization, showing that if you have a combined anti-HLA and anti-ABO sensitization, it could be a big problem. To deal with ABO sensitization itself is much easier as compared to anti-HLA sensitization, and anti-HLA sensitization is one of the important barriers which you have to overcome, and you really need to look for it, even for patients who are going for the nuclear studies. Little was also done in patients with chronic allograft dysfunction. And what we found that in patients who had chronic allograft dysfunction, the suppressive function of the CD4 positive and CD25 and FOXP3 positive, it was actually lost in patients who were having chronic allograft dysfunction. These are all in vitro studies. How much would they translate into in vivo is actually only could be evidenced by clinical studies. This is the mythological figure which shows Prometheus, where the regenerative power is supposed to be indefinite. The regeneration could occur of organs or whatever damage occurs, which is what a human being wants, that if we can produce our own kidneys, repair our kidney damage, that would be very fantastic. The tolerance which we look at, the classical tolerance is total tolerance, and operational tolerance, which looks like tolerance, but is something which can really break down, and almost tolerance, which is actually with minimal immunosuppressive drugs. All these things are possible if there is a window of opportunity for immunological engagement without a destructive component of the thing. Whenever there is an immunological engagement, there is a possibility of destruction which can occur, which we call as the host versus graft reaction. So this hypothesis is like a football match which is going on in a stadium, everything in a very orderly manner, but a one wrong signal and a wrong decision, you find all the spectators on the ground and there's a total chaos, just like a rejection which can occur suddenly in a patient who looks all fine and we don't know what is happening. And as soon as the security comes, like the anti-rejection is given, you find again things are in order. So the top tolerance is what we are seeing at present, where you do an induction and you try to produce alloantibodies, which is clinically used looking for the antibodies by single antigen bead assay. The other tests which I have mentioned, whether lymphocyte functions, proteins, or gene transcripts, they have been standardized and also shown to be of some benefit. But at present, clinicians are not using them routinely for transplant care. It may happen in future. These tests like the K-sort and the AliSpot assay, There are the other two which showed a lot of promise, but ultimately they were only shown to be useful biomarkers of success or failure of treatment of biopsy-proven acute rejection. They have been studied, there is a lot of data available, whether they can pick up early rejection and whether they can tell you subclinical rejection. All those studies are there. Some of them are positive, some of them are negative. What we are looking for is at the time of transplant, at day 0, you have a protocol by which you are able to induce tolerance. Not possible at present. This is what would be the ideal. And then you look at biomarkers of tolerance. It could be gene-based or flow cytometry. The anti-donor immune responses, which I mentioned, especially anti-HLA antibodies, single antigen B, they are the ones which are very practical and used also. After those induction protocols, you evaluate these patients. You would like to evaluate and try to find out if tolerance has occurred. There are no biomarkers at present which are available, but there are many which have been studied. If you have a clue that there are positive biomarkers of tolerance, what we would aim is to cut down immunosuppression and tailor down. This is a regime which we would call as patient-oriented care. But practically, this is not what we do. We treat these patients in a protocol-based immunosuppression, which is variable depending on the HLA antibodies, depending on the ABO compatibility, depending on the second transplant, depending on sensitization. But this is what we would love to reach there. So it is desirable that the information, whatever is available by the so-called genetic studies, could be used for a personalized drug therapy, and then use these transcripts for genetic biomarkers for post-transplant immunosuppression as well. This is a diagram which tells you that genetic profiling could be of help for, say, looking at how much CNI dose you could use. It could be of useful to see how much MPA, because they are telling you with this genetic profiling how the individual is going to metabolize the drug. So you could get a clue, and before transplant you could use immunosuppression in a different way. But you might say, what the hell, I will do the levels, and then in living donor the levels would guide me. It's much cheaper and equally effective. The same model which I showed you for pre-transplant, at present detection of HLA antibodies is the one which is practically used. The ALISpot cave with lot of promise, but at present not done as a routine. Gene expression is a promising thing, but still is being researched. And the rejection prediction is also at present clinical and biopsy based. But we are looking at biomarkers which would be non-invasive and could guide us much better. There are several research programs going on. One of them I am just mentioning, a biomarker-driven personalized immunosuppression, BioDRIM, which is looking at, this consortium is looking at how we could wean the immunosuppression in liver and kidney transplant. And these are all high throughput data collection and analysis. So still it is in the research mode. Individual patients, how those results would be used is difficult to say. One example I would tell you that mTOR inhibitors, they came with a lot of promise, and then that promise was almost gone. We stopped using mTOR inhibitors, but now we are finding the same mTOR inhibitors trying to show that there is a promise. So if you get similar group of better drugs used in a more systematic manner, probably they have promise, because now we know that previously we used to avoid using mTOR inhibitors, rapamycin, and CNI, but now the protocols say that you actually start using them from day zero uh, in a reduced dose. Previously, we were worried that they will produce lymphocytes, poor wound healing. All that has not been really confirmed. So they say you can use it. It will not negatively impact in terms of the surgical healing. They could have benefit in some cardiovascular and neoplastic complications which could occur. So that's how there's a mixed induction followed by everolimus, low dose tacrolimus starting from day zero, again came back, and there are studies which have shown that this could be a promising immunosuppression regime. You can see that since the immunosuppression came into being used, in 1954 there was no immunosuppression, but it has changed. How it has changed, like the purple one shows you that MMF has taken over completely by 2004. And the tacrolimus, as it came in 97, by 2004, this lower one is anti-thymocyte globulin, which is also an interesting story. As it started being used, it became almost a universally used induction therapy, even in living donor transplant. There are registry data showing this is the best drug, safest drug. And in US, the transplanters started using thymoglobulin induction even before FDA approved it. They started using. FDA approval come much later. I remember that ATG, when the FDA was approving, in Paris, they had to close their factory. They have to make a new factory in USA and do the trials. And only after those trials, FDA US approved it. But even before that, the transplanters in USA were using, there were no big randomized studies, but they found it very useful. What has happened, even with the clinical approach of the transplanters and with the immunosuppression which we have, the rejection rates have drastically come down. This is the true story. We can't deny it. This is registry data with all possible drawbacks. The rejection rate came down to below 10%. So they say if you've achieved this with the immunosuppression which you're having, if you go next step forward, it is not easy to show that things would be much more superior. So you have to have large number of patients. You have to show in studies that rejection rates can be brought down further, which has not happened. So what they are trying, this is a very interesting diagram showing how from December 23, 1954, when first transplant was done in Boston, over all these years till 2020, the transplant scenario has changed. Many places you will find, besides thymoglobulin, besides inflammasome receptor, MMF, belatacept, it is the legislation which has proved a very important role. The availability of drugs, the way they are being provided, all that, the way the organs have been allocated, they have played a very important role, not only in expanding this program, also in improving the post-transplant care. So we have to keep in mind it's a complicated scenario where somebody is donating the organ and you're using it for patient care. In different solid organ transplants, you will find that the different regimes are being followed. Like in liver, nobody uses thymoglobulin induction. Liver, the immunosuppression is much less in terms of the degree of immunosuppression. But in other solid organ transplants, including lung, kidneys, the thymoglobulin induction has almost been used in a large way. As the rejections came down dramatically to less than 10% in the registry, the antibody-mediated rejection has become very, very crucial and very important. And people are worried how to treat. At present, we have plasmapheresis, IVIG, methylprednisolone, the standard protocols, which are many times not successful. These are some of the studies which are trying to look at the IL-6 inhibitors, the C1 esterase inhibitors, and the using IDS, which leads to anti-HLA antibodies for treating and also for preventing AVMR, because it is the AVMR which is most crucial for long-term outcomes. Even development of antibodies, anti-HLA antibodies, plays an important role in the long-term transplant success. The clinicians are very eager to move beyond the traditional short-term survival. We all want 15, 20 years. Like I said, the first one of the patients transplanted in 79 is still surviving after more than 40 years. This is what we want in most of our patients, but it is not possible at present. So everybody wants an individualized post-transplant immunosuppression regime and needs to balance, because in India, infection is one of the important causes. Even earlier, the ASA-PRED immunosuppression infection was a big killer. There's recently a hype about the commercially available kit, which is the AlloMap or TrueGraph, which is a non-invasive diagnosis of immune-mediated allograft injury. And it is basically combining the gene transcript-based biomarker and the donor-derived cell-free DNA, which when it came had a lot of promise. Then they showed clinically it may not be that useful. So they are combining these two techniques, and within 4 days the results come. At present, rather than diagnosis of rejection, for which nobody is going to wait for 4 days, you have to immediately act. It is being promised that it will be useful to diagnose subclinical rejection. It may be useful for tailoring individualized post-transplant immunosuppression. This is one of the data which we analyzed. This was patients in Medanta, Lucknow, where during the COVID outbreak, we found that these patients who were continued to be on dialysis versus those who went for transplant. Those who went for transplant, the mortality was just 2.8% versus the 14% or almost mortality, 20% mortality if they were kept on dialysis. So transplant, even in the COVID peak, this was the second peak I'm talking, not the third one, was possible, was successful, and this is one of the, Dr. Kute had, I don't know, 50, 60 publications in this area. Is one of the publications we were also participating. Their COVID recovery patients, they could be also transplanted. So he has had a lot of multicentric data collection showing that COVID is no barrier for transplantation. Fortunately, now COVID is gone. I mentioned about this transplant genomics OmniGraph kit, which is combining the cell-free DNA and the gene-based biomarker as a non-invasive test panel, but the results come within 6 days. So we are looking now if it is possible to have non-invasive biomarkers rather than doing the kidney biopsy, both for delayed graft function, acute rejections, and chronic allograft failure. So this kit which I mentioned, combining the donor cell-free DNA and the genetic biomarkers, is being studied in this area. At present, I will not say that it can be used for a routine patient care, but maybe the data may suggest. Lastly, I am going to show you, this is one of the studies published in 2020, where they did basiliximab induction. This was a randomized study, but not a big number of patients. And they did MMF tapering. And what they found, and steroid tapering also, in patients who were not sensitized, because the low risk patients, you can even very early, within 1 or 2 weeks after the basiliximab induction, taper off and withdraw steroids. While patients who were high risk patients, having the high antibody profiling, they could withdraw MMF also and keep those patients only on tacrolimus and steroids, just dual immunosuppression. So both low sensitized patients, you continue after stopping steroids, tacrolimus and MMF. High risk patients, you stop MMF and continue them on TAC and steroids. This is a clinical study, not very large number of patients, but it is possible with the type of immunosuppression that we have to do steroid withdrawal and even MMF withdrawal, which they have benefits. I will end again by showing this painting of Gilles Borel, who was the discoverer, one of the discoverer of cyclosporine. And cyclosporine, though they never got Nobel Prize, maybe in the next 10 years they might, was the key immunosuppressive drug to improve the success of transplant. It was so successful that the transplant surgeons started saying there is no need to do HLA typing, there is no need to do anything. Give them cyclosporine and transplant them. But that has not been borne out. The other was of Tom Stargell, which you heard by his name. Stargell Institute is there, and Roy Can is shown in the third photograph where he's shaking hands with the Pope during one of the meetings. So I think I would like to thank again for giving me this opportunity. The transplant story is very absorbing to read and also very absorbing to narrate. So thank you very much.
Thank you, Professor Sharma, for such an illustrious lecture. I think you have taken all of us along, not only your own nostalgic story, but also the story of the entire transplantation, the summary right from the beginning to the xenotransplantation. So thanks once again. And Dr. Dharmen might like.
So thank you for this fascinating journey, this illustration of, as customary in oration, we don't have any question.
I will request all chairs and co-chairs to felicitate Dr. Sharma with our oration plan.
Thank you, sir, for sharing your experiences and taking us through the journey on how transplantation has evolved over decades. We thank chairpersons for presiding over the session. Moving on to the next session. Next session is on monoclonal gammopathies and the kidney. will be by Professor Dr. Sanjeev Sethi, sir, from USA. To chair the session, may I invite the chairpersons, Dr. Manoj Jain, Professor, Department of Pathology, SGPGMS, Lucknow. Dr. Kora, Consultant Nephrologist, Indore. Professor Dr. Amit Gupta, sir, former HOD and Professor, Department of Nephrology, SGPGMS, Lucknow.
I don't know if you can hear me. Can you hear me?
Yes, sir.
Hello? I cannot share my screen from here. It's not giving me it's not allowing me to share my screen. Hello?
Dr. Sethi, you are quite audible. So,
But I cannot share my screen. It's not allowing me to share my screen.
I am just telling these technical persons to allow you to share your screen. So, first of all,
Good afternoon, sir.
Yeah.
Professor Sethi, can you hear us?
I can hear you, but I know it will not allow me to share the screen.
Okay. So they are just sorting it out.
yes, sir. Sir, now you will be able to share your screen. Kindly share.
No.
No.
Good afternoon. Good evening, sir.
No.
It's a late evening, I think, there in US, and I thank you for sharing time with us.
I don't think this is going to work.
So, can you try, sir, if you would be able to share your screen, please?
I have the lecture open, but it is blanking out. It just says it is some security reasons. It will not let go. I am going to log out and log in again. Can you wait for 1 minute?
Oh, okay, sir. Thank you very much.
Okay, I will do this one more time. Just give me one.
Despite having COVID, you have joined today.
First of all, I thank Department of Nephrology for organizing such a wonderful CME on glomerular pathology, glomerular disease, which is of interest for all renal pathologists. Yesterday, all you have witnessed how department has grown from very beginning in 35 years, Professor care time. So I witnessed also, I joined department 93 here in the department as senior as well. And this department was further nurtured by Professor R.K. Sharma, Professor Amit Gupta. Now it is in hands of Dr. Lion Prasad and his team. And I wish in future also this department will make its recognition national and international level as it is doing. So, it is my proud privilege to introduce Professor Sethi here to the August audience. He needs no introduction. He is a senior consultant in Mayo Clinic. And Dr. Sethi is basic researcher in renal pathology. He has dedicated his whole life in renal development of renal pathology and basic research. He has many key publications in the just consensus classification of glomerular nephritis, even international myeloma MGRS group. He is co-author. So in membranous nephropathy is also many research. He has done a lot of new. Yesterday you must be listening membranous nephropathy. So a lot of latest whatever the Dr. Sethi's research is there, and he has done innumerable publications. He dedicated his whole life to renal pathology. I think Dr. Sethi will be joining us today. It's always privilege to hear Dr. Sethi. Today he will be talking on the myeloma and kidney diseases. It's the area of interest for nephrologists, for pathologists and hematologists, as this disease requires high degree of suspicion for the nephrologist, and equally it is important for renal pathologists to do full diagnostic workup. It's really challenging many times to pick up MGRS in the kidney, and their diagnosis is very crucial for the patients, as the treatment botulism clonal directed therapy is very important for the successful management of these patients. I think Dr. Sethi will be logging in and He will be delivering this talk. Okay, Dr. Sethi. Now we can see your slides. We cannot hear you. Hello, Dr. Sethi, can you hear us?
Can you hear me? Can you hear me? Can you hear me? Can you hear me? Can you hear me?
Yeah, you can hear me.
There is a problem
There
here.
is a problem here.
I'm not sure what to do. Not sure what to do. Not sure what to do. Not sure what to do.
Dr. Sethi, your mic is muted, I think.
Can you hear me? Can you hear me? Can you hear me? Can you hear me?
Yes, sir, you are audible, sir, but probably you have device off. So then echoing will be corrected. So make one device off.
Can you hear us, Professor Sethi?
So, you are audible. What is happening? There is a lot of issues. Probably you have logging twice. So just one logging out.
Can you start? I mean, can you speak up? I mean, maybe you can try again.
Now you can try, sir. Yeah, probably you can do that. Your voice is not fine. So can I? Yeah, you can connect with this phone because that might be fine. Hello? Yeah. You can start with now, and I will let my mobile on.
sick on Tuesday. Wednesday, I checked myself and I had COVID. But it is better now, so I'm okay to stop. So my topic is going to be monoclonal gammopathies and the kidney. Before anything we talk about monoclonal gammopathy, we need to understand the basic structure of the immunoglobulin. Okay, so this is what the immunoglobulin IgG is the class of immunoglobulin we talk of. This is the basic structure. It has a heavy chain over here, and then it has a light chain over here. So there's one heavy chain, one light chain. In each B cell or plasma cell makes the exact same immunoglobulin. The same heavy chain and the same light chain with the same concentration and the same variable region. So that's an important concept to understand for when we talk about monoclonal gammopathies and kidney disease. Keep in mind that one plasma cell or one B cell will make the exact same immunoglobulin. No two cells are alike. So some background before we go into the monoclonal gammopathy study. Typically, intact immunoglobulins are large molecules and they do not go through the glomerular capillaries. On the other hand, small amounts of free light chains can be filtered through, but they're all reabsorbed in the proximal tubules. So in the urine, you should not be seeing any free light chain, even though small amounts are being filtered. So if you look over here, this is the way the capillary wall functions. This is the capillary wall here. Very small molecules like inulin and dextran can go right through. On the other hand, beta microglobulins, myoglobulins, through rhabdomyolysis, and like I just told you, some light chains with more molecular weight can squeeze through, but the larger ones, they have a dimer, albumin, IgG, and bigger molecules do not go through the capillary wall unless there is injury to the capillary wall. So this is a very basic concept to understand that in general, immunoglobulins and light chains do not go through the capillary wall unless the capillary walls are injured by some mechanism. Just some backgrounds. Okay. Now let's talk about monoclonal gammopathy. Okay. The term monoclonal gammopathy refers to overproduction, like I told you, of that IgG being produced by that single plasma cell or the single B cell. So it's the same immunoglobulin that is overproduced by that one B cell or one plasma cell. So this plasma cell or B cell has a clonal proliferation, but it's the same cell basically producing the same immunoglobulin. And when it is produced in enough quantity, it is dissected. You can detect it in the blood, and the term, because it's molecule, we use the term M protein. And like I told you before, most of the M proteins contain both the heavy chain and the light chain. Remember, it is that one B cell or that one plasma cell taking the same immunoglobulin in large amounts. Some rare cases, you can get only kappa and the light chain. Even less common could be only the heavy chain. But most common is both the heavy chain and light chain being produced. For example, you could have an M protein that is IgG kappa, or you could have an M protein that is IgG lambda. How do you detect this? The easiest technique that most labs will do are simple protein electrophoresis, where you run the serum or the urine and then you look for bands. This technique is somewhat less sensitive. It's quite specific, but less sensitive. It does not tell you what the band contains. It only points out the M protein. So you do not know whether it's IgG or whether it's IgM or IgA. For that, you need to do immunofixation electrophoresis, where you use a specific antibody to detect what's in that band. Keep in mind, immunofixation electrophoresis, again, although very specific, in some cases will not pick up this monoclonal immunoglobulin if it's in very low amount. And also, IFE usually does not detect, if I'm not mistaken, IgD. E stain for IgA, E stain for IgM, IgG, and IgE, but we do not do IgD. So IgD will be missed based on immunofixation. Mayo Clinic was instrumental in coming up with what's called the serum-free light chain ratios, where you don't worry about the heavy chain, but you look at the kappa and lambda light chain ratios, and if the ratio is normal, you can infer that the patient has a monoclonal protein in circulation. Once any of these three are positive, the next step would be to go to a bone marrow biopsy. And of course, there you will be able to detect the plasma cell and B cell. Now, we're talking about monoclonal gammopathy and kidney disease. The way I see it is, you can have a plasma cell abnormality, or you can have a B cell abnormality. It's that one cell that takes off, becomes proliferative, and makes more and more of the monoclonal abnormality. The way to look at it, at least the way I look at it, is under the plasma cells, you can have a malignant clone, and this would be multiple myeloma, and I will go through the criteria, or it can be small ring multiple myeloma, or you can have Waldenstrom's macroglobulinemia, which is really an IgM secreting B cell or plasma cell clone. Now, in the non-malignant portion is what is called MGUS. That means, yes, you have a clone here that's making the IgG cap or IgG lambda, but it doesn't fall into the malignant criteria by the Hematologic Society criteria. Okay, we will get into MGRs very quickly. On the other side is the B cell lymphoproliferative disorder. This is much less common than the plasma cell, but the story is the same. You can have a malignant condition, it could be B-cell lymphoma or leukemia, or you can have what's called the dangerous B-cell clones or an MGUS arising from the non-malignant or pre-malignant B cells. So, very simply put, these monoclonal immunoglobulin has to come from either plasma cell or B cell. Now, in the plasma cell, you can have a malignant condition. In the B cell, you can have a malignant condition. This forms actually the bulk of the renal conditions. However, a small portion of renal conditions can also arise from patients who have what's non-malignant or the pre-malignant condition, and that's called the MGUS. MGUS is much more common than Waldenstrom's or multiple myeloma or small ring myeloma, but the disease causing is much less compared to Waldenstrom's, multiple myeloma, and small ring multiple myeloma. So you have to keep that in mind. Now, in the good old days, it was quite easy. The classification was straightforward. You had MGUS, that was the pre-malignant, and these patients had an M spike, which was very small, less than 3 grams per deciliter. If you did a bone marrow biopsy, you found they had less than 10% plasma cells or B cells. And all the other features, what's called the trap features, were negative. On the other hand, multiple myeloma was at the other end of the spectrum, greater than 3 grams, greater than 10%, and then they had the trap features. In between is the small ring multiple myeloma, which is similar to MGUS, except that they had more than 10% plasma cells. The important thing to remember here was MGUS, when it was described, it was called malignant or monoclonal gammopathy of undetermined significance. At that time anyway, the significance of MGUS causing kidney disease was not well understood. And this is where the whole concept of MGRS has come in. The initial concept of MGRS was quite straightforward. So let's look at this again. I just gave you the classification. Here is MGUS. Small, less than 3 grams per deciliter of spike, less than 10% plasma cells of bone marrow, and no end organ damage, no myeloma defining events. That's the CRAB feature. So this is MGUS. For me, MGRS is exactly the same as MGUS. That means less than 3 grams of deciliter of M protein, less than 10% bone marrow plasma cells. The only difference is now you have a monoclonal immunoglobulin causing a kidney disease. So this does not fit into the multiple myeloma because it doesn't have more than 10%. It doesn't have more than 3 grams. So this is what MGRS was initially, at least when it was first described, that this is equivalent to MGUS except you have kidney disease now. Okay. And smoldering multiple myeloma is not the same as MGRS because you have much more plasma cells here and more than 3 grams per deciliter. The issue here was many patients of MGUS were not treated. And the idea was now that you have an MGUS causing monoclonal sort of renal disease, we should be targeting these patients. So this was the initial definition. MGRS is equal to MGUS but with kidney disease for monoclonal immunoglobulins. Subsequently now, this has been modified a little bit. While this is also still true, patients who have smoldering multiple myeloma and some low-grade lymphomas that may not be treated by the hem-onc people, but are causing kidney disease, are thought to be felt as equivalent to be under MGRS. So initially MGRS was MGUS plus kidney disease, but now any disease entity with monoclonal gammopathy that the hematologist will not treat is called MGRS. So it's become a bit of a wider spectrum. Now let's look at the next step. So that was the MGRS concept, okay? And we'll get into the MGRS a little bit more towards the end. I like to simplify the monoclonal gammopathy-based kidney diseases as those involving the glomerular, involving the proximal tubule, and then involving the cas nephropathy, or the distal tubules. The glomerular diseases are basically immunoglobulins getting stuck in the capillary walls. Like I told you initially, immunoglobulins themselves do not pass through. So when immunoglobulins get stuck along the capillary walls, depending upon the physiochemical nature, they can either cause a proliferative glomerulonephritis or immunotactoid, or rarely the monoclonal tubulate. So these are intact, complete immunoglobulins. So you might ask me, how about amyloidosis and MIDD? These are not intact, these are light chains or heavy chains. In these cases of amyloid and MIDD, the light chains, because of its physiochemical nature, either binds to matrix proteins and does not go through the capillary loops, that's MIDD. In amyloid, the light chains bind to chaperone proteins like the apolipoproteins. So as a result, they also become large molecules that cannot go through the capillary walls. And as a result, the disease occurs primarily in the On the other hand, when the light chains go through, it will reabsorb, again because of the physiochemical nature, the proximal tubule, you get light chain proximal tubulopathy, much less common, and most of them that go through and get stuck in the distal tubule, and these are called distal cast nephropathy, which is related to the extent or the levels of light chains being secreted through the glomerulus. There are two ways to look at the pathology of monoclonal immunoglobulin-associated diseases. I like to look at it this way. It's more easy for me as a pathologist. If I see the glomerular or the interstitium or any of the others having the monoclonal immunoglobulin on immunofluorescence microscopy, I know that the immunoglobulin is causing the kidney disease. So I call this the direct mechanism. That means you are seeing on immunofluorescence or immunohistochemistry the monoclonal. Described out of Mayo Clinic. And now it is quite well established. So you can have a monoclonal immunoglobulin in circulation, that means an M plus, or a B cell lymphoma, yet you have a glomerular disease like C3 glomerulopathy or thrombotic microangiopathy, in which you don't really see the immunoglobulins. And this is what I call indirect mechanism. That means the monoclonal immunoglobulin is interfering with some sort of a pathway that results in C3 glomerulopathy or a TM. And both of them are quite well acknowledged. So what I like to say over here, most of the lesions are direct. That means as a pathologist, we can identify the immunoglobulins of the biopsy and we can determine what the disease entity is. Less commonly, you can have other diseases also related to the monoclonal immunoglobulin, but you do not see the deposits on biopsy. There is a great degree of heterogeneity if you think about it. So the pathology, you can see how many different diseases you have: glomerular diseases, interstitial diseases, vascular diseases, and then the indirect diseases like C3G and TMA. Similarly, when you go to the clinical story, it's very heterogeneous. And so you can see patients can present with acute renal failure. These are typically of myeloma kidneys or TMAs. Patients can come with nephrotic syndrome. These are amyloids typically, or MIBD. Patients can come with a rapidly progressive or nephritic picture. This is your PGNMID or thioglobulins. Or even immunotactoids can present with nephrotic syndrome. And then many of these diseases can present with progressive CKD. And we see these on the biopsy all the time that, there's MIDD, but it's so chronic at this time. Or TMA is quite chronic at this time. So progressive kidney disease can also be caused by monoclonal immunoglobulin. So just to recap a little bit over here. One is the kidney biopsy is typically required to detect monoclonal immunoglobulin-associated kidney disease. These diseases can be caused by a direct mechanism where the immunoglobulins are deposited in the glomeruli or tubules, or even in the interstitium and vessels, which we're not talking about today. The treatment and prognosis is very dependent upon what the disease entity is. So a myeloma kidney or a cast nephropathy from a myeloma is very different from light chain proximal tubulopathy, even though both of them result from monoclonal immunoglobulins within the tubules. And finally, I want to stress that NGLS is a good concept to have, that patients with monoclonal immunoglobulins can cause a variety of kidney disease. We should not use this as a primary diagnostic entity. Okay, because then it makes things very so you have to realize that the glomerular diseases are different, the hematologic diseases are different. And we need to make the diagnosis of the glomerular disease individually, and we need to work these patients up for the underlying hematologic condition. To put everything into a common term of MGRS is probably not the ideal way. It is good to bring awareness, but I don't like the diagnostic term of MGRS. A myeloma is very different from a light chain proximal tubulopathy. B-cell lymphoma is very different from, again, multiple myeloma. And even though they may cause the same kidney disease. So you have to keep in mind to lump everything into MGRS, while good conceptually is not the ideal diagnostic line that should ever be in a renal pathology report. And I've seen this time and again. The patient, they say, I can tell you this from last week. Doctor, that the patient has MGRS. So I tell the clinician right back, what do you mean he has MGRS? Oh, does he have he has a monoclonopathy, and does he have a kidney disease? I said, yeah, he's got a kidney disease, the only thing is diabetes. So the problem, I don't know if I'm getting this across, the problem with MGRS has become sort of a waste paper basket story, and we have to be careful with that. So the way, again, I see it, and I'll give you 4 examples, and then we can call it quits. There are 4 scenarios typically. The first one is that patient has a detectable serum immunoglobulin, monoclonal. And this is the bulk of the patients that you and I as a pathologist will see. And when you do the kidney biopsy, there is no monoclonal immunoglobulin disease. 80% of my kidney biopsies that I get who have patients who have monoclonal immunoglobulin fall into this category. And I'll get into this. The second is the patient has a detectable monoclonal immunoglobulin. And sure enough, you have a renal disease from the monoclonal immunoglobulin. The third scenario is the patient has a detectable monoclonal gammopathy, and the disease entity is indirect. Talking to that. And the last one is the most difficult. The patient has no detectable monoclonal gammopathy, yet when you do the biopsy, you find the monoclonal gammopathy. So these are the 4 clinical scenarios. Let's go one by one. And I'm going to jump a few things, okay? Let's give you a few examples. This is a 50-year-old man with hypertension, diabetes, including chronic kidney disease. His creatinine has gone up from 1.7 to 2.2 while the workup is going on. Currently, the creatinine is 4.5, up from a baseline of 2.2. In any case, when the workup is done, he has an IgM kappa monoclonal immunoglobulin. The biopsy is done, and you can clearly see every glomerulus over here is involved by these large nodules. Some glomerular globally sclerosed, Congo red is negative, beautiful silver and PAS positive nodules. EM shows you these large mesangial nodules with nothing going on. So clearly this patient has diabetic nodular glomerular sclerosis. And so this is what I do in every case. I will call it nodular diabetic glomerular sclerosis. I will give the extent of scarring, and then I will make sure that I tell the clinician that even though he was biopsy looking for an MGRS lesion, there is no evidence of a monoclonal immunoglobulin related lesion. This is the bulk of the biopsies that I get with patients who have a monoclonal immunoglobulin. Okay, I am going to jump a little bit. Next, go to the next patient. This is a 61-year-old man with acute renal failure, back pain. Again, he has an M spike. And in this case, the biopsy fits what the clinician was taking. There's ATN, and then there are lots of tubules with these fractured casts over here. Very typical casts of myeloma kidneys. They have geometric shapes. They are surrounded by an inflammatory infiltrate. Compare them with the Highland cast. And when you do immunofluorescence, they light up for lambda light chain. In this case, alpha light chain is negative. So clearly, this patient has light chain nephropathy. So this one fits the story, and I will say over here in the comments the findings are consistent with the patient's documented multiple myeloma, gas nephropathy is a myeloma defining event. Next case. So I'm going through the various scenarios of monoclonal gammopathy and kidney disease. This is a 69-year-old man with hematuria, proteinuria, renal failure, serum creatinine of 2, urinary protein of 2.8. Electrophoresis studies again shows a monoclonal gammopathy. In this case, again, you have these nodules that are silver and PAS positive. In this case, when you do the IF, lambda light chain is negative, kappa light chain is positive, and the EM shows you this nice granular deposits along the TBM. So this case, it's a straightforward case of light chain deposition disease. I will make sure I give you the chronicity. I will tell you that the congruent stain is negative, and then in a comment tell you the finding that is consistent with the patient's documented multiple myeloma. If you know it. Let's give you a break. Keep in mind I have COVID, so I am isolated here in the basement. So this is a 71-year-old man with history of diabetes, presents with increasing proteinuria and edema, serum creatinine of 1.6, and he has a stem spike for IgG lambda. Kidney biopsy is done. Again, a relatively easy diagnosis. We show you the mesangial nodules here. You can also see thickened arterial walls. When you do the congruent, it's nicely positive, as you can see over here. And this is the birefringence. The stains for lambda light chains, kappa light chain negative. EM shows you the fibrils. So this is a straightforward diagnosis, amyloidosis, lambda light chain type, give you the congruent stain, give you the extent of chronicity, and in this patient also if he has myeloma, we say it's consistent. So those are the conditions that are easy ones where you see the immunoglobulins on the monoclonal immunoglobulins on the IF, and then you put the story together and come up with the precise diagnosis. The next one is when you don't have monoclonal immunoglobulins in the serum, yet you see GN or any other disease on light microscopy and IF and EM showing your monoclonal. Okay, so let's look over here. So this is a 58-year-old man. I think I jumped the gun a little bit. I apologize. Let's see this there. Yeah. Apologize because the COVID is working. Okay, so let's go back to this. So this is the third one is when the serum or the urine immunoglobulin workup does not show any monoclonal. But when you do the kidney biopsy, then you see monoclonal immunoglobulin mediated kidney disease. The most common one, the most typical one is the PGMMID, what's also called the proliferative glomerulonephritis with monoclonal problems. Okay, that means as a pathologist, I can see the monoclonal immunoglobulins on the biopsy, yet as a clinician, when you do the workup, the blood, or the urine, or the free light chain, you will see there's no effect. this is your typical case. This is a 51-year-old, 58-year-old man with nephrotic syndrome, hypertension. In any case, this patient you can see has a GN, empty GN like picture. He has IgG, lots of C3, kappa light chains, lambda light chains is negative, so clearly he has an IgG kappa PG and MID. In this particular case, we were able to find kappa light chains in the urine, although the serum was completely negative. We can subtype these patients to look for monoclonality, and most of these, about 70% of these, could be IgG. Okay, so that's the diagnosis here, PG and MID, IgG3 type, pattern of injury and PGN. Here is the chronicity, congruent stains are negative. And in patients who don't have a circulating non-immunoglobulin, I give a comment saying serum urine studies are negative for non-immunoglobulins. While such negative findings are frequent in patients of PG and MID, the glomerulonephritis in such cases is nonetheless considered to result from deposition of monoclonal. Because these patients have very quick recurrence and many other factors, this truly is considered monoclonal immunoglobulin-mediated disease. The last one is what I mentioned earlier. You can get a monoclonal immunoglobulin, yet the kidney biopsy does not show the monoclonal immunoglobulin. Instead, it shows you either C3GN or TMA. So here is one case, 61-year-old man who had a monoclonopathy. This patient was at the Mayo Clinic, and he was biopsied 2 times, once in New York and once, I think, in California. And eventually, I saw the biopsy. So this patient was called post-infectious GN, but he had no infections. On the other hand, he had a small MGUS at the time. This is almost 15 years ago in this case. And the biopsy clearly showed a proliferative glomerulonephritis and PGN. I had showed bright C3 and numerous mesangial capillary wall deposits. All the other immunoglobulins were negative. So, of course, this was a C3 glomerulonephritis with monoclonal immunoglobulin associated. At that time, when we described this entity was not known. So I was the first one to pick this up, and we described the case series, I think, in 2012 or 2013. Quite old now, but it's quite well established that non-glomerulopathy can cause C3G. So this is the indirect mechanism. So this is again how I would classify it: C3 glomerulonephritis, MPGN pattern, extent of scarring. I also say congruent stain is negative. There is this entity of masked immunoglobulin. It's extremely rare. I've seen it only very rarely, 1 in like 40 cases. But if we have a C3GN and the patient has a monoclonal immunoglobulin, it makes sense to do Crohn's immunofluorescence studies. What this does is it converts a C3GN into a PGN-MID if you find the monoclonal immunoglobulin deposits on the Crohn's. It's very rare. So a couple last slides. I apologize for my presentation because I'm not feeling so well. There is a great heterogeneity in renal disease. That means you can have glomerular disease, you can have tubular disease, you can have interstitial disease, you can have vascular disease. You can have disease from direct deposition, or you can have diseases from as a result of an indirect mechanism where there is no direct deposition of immunoglobulin. There is heterogeneity in the hematologic conditions. So you can have a plasma cell disorder, you can have a B cell disorder. Plasma cell disorder could be malignant, could be platelet. Same thing goes with the B cell. There is also heterogeneity in the clinical presentations and outcomes. So, an amyloid or a myeloma is not the same in terms of clinical presentation or outcomes compared to a light chain proximal encephalopathy or crystal global anemia, which is much slowly progressive and low-grade disease entities. So you have to keep that in mind as well. And like I said, I'm not sure I like the terminology of PRS. While it is okay to use, to bring a sort of mindset, I would say, to say that patients with undetermined monoclonal gammopathy can also have kidney disease, but don't use it as a diagnostic entity. And I will say that a close interaction between the nephrologist, pathologist, and hem-onc person is critical for management of all these diseases. And I will stop here because I'm not really feeling well enough.
Dr. Sethi, can you hear me?
I can hear you. I'm sorry about it. I don't feel so good, you know. Yeah, go ahead.
Thanks for a nice presentation. As everyone will agree that it's a heterogeneous disease and challenging for the nephrologist, hematologist, as well as for the renal pathologist to diagnose myeloma. So we have got some queries. Number one, how you define the range in CKD patient? For that
Dr. City, you are audible?
Okay, I can hear you.
Yeah. So, few query from Dr. Manoj Jain.
I'm Dr. Manoj and Dr. Sethi. Good evening. I think it's a late time you are taking this talk. My query is that how you define the serum free light chain kappa lambda ratio in CKD patients, because that defines the MGRS in many patients. And sometimes we get discordant report. In serum there is kappa predominant, whereas in tissue we see light chain in immunofluorescence. So how to explain those findings?
Not sure I understand the question.
So my question
But my take on it is, if, like I said, don't make MGRS into a disease condition. It is not either a hematologic condition, because it's not a hematologic disease, right? And don't make it into a kidney disease. So I feel it is the terminology of MGRS is good as a concept, but no patient should be labeled patient has MGRS. The patient should be labeled with exact kidney disease and exact hematologic disease. So if the patient has on a kidney biopsy amyloidosis, we call it amyloidosis. And then on the bone marrow biopsy or the hematologic workup, the patient has a myeloma or a smoldering myeloma, you call it that. I would not call it, if he has an MGUS level, that means everything else doesn't fit. You still don't call a hematologic condition MGRS. MGRS only for, I would say for a concept, for an understanding. Although I don't think I answered your specific question, but I didn't understand the question.
How physicians should proceed, because if MGRS then clone-directed therapy has to be given. So if we are giving in our report MGRS, and based on the criteria, defining criteria for your article.
No, you never write in a report MGRS.
Okay. You will be writing primary disease.
You cannot give a diagnosis of MGRS.
Thank you.
We
Thank you,
had a
sir.
monogramopathy meeting here, and I think the one thing that we published in our guideline was the pathology report should never say the patient had MGRS.
Okay. So, as far as treatment is concerned, so clonal-directed therapy should be given only when hematological malignancy is there. That's what you say. Okay. Any questions from the audience? We can take up and we can just ask. Okay. Dr. Amit Gupta,
Thank you so much, Professor Sethi. That was a wonderful lecture, and I'm grateful that you could speak to us. Yeah, you could speak to us. You could, you could speak to us while you, despite the infection. Thank you so much indeed, and all the best for quick recovery.
Thank you.
Now the next session will be on update on IgA nephropathy by Dr. Jonathan Barrett from UK. To chair the session, may I invite chairpersons Dr. Mohan Rajpukar sir, Honorable Medical Director and Member, Board of Governors, NADIAD, Professor Jaiprakash Oza sir, Senior Consultant Nephrologist, Varanasi, Dr. Saurabh Pokhriyal, Consultant and Head of the Department of Nephrology, Manipal Hospital, New Delhi, Dr. Abhilash Chandra, Additional Professor, Department of Nephrology, RML Lucknow.
Well, the next session is by Professor Jonathan Barrett, who's the Professor of Renal Medicine at the John Walls Renal Unit, Leicester General Hospital, Head of Postgraduate Specialty School. His work on IgA nephropathy and also the pathobiology of it, and work on new molecules to be used in IgA nephropathy is in stage 1 and 2. I request that his lecture may be started. I believe it is recorded lecture. Please start.
Hello, I'm Jonathan Barrett, and it's a real pleasure to be joining you in this CME on glomerular disease. I'm a professor of renal medicine at the University of Leicester in the UK, and it's a real shame I can't be with you today to patients on dialysis globally is on dialysis because of IgA nephropathy. And of course, we also know that if patients are lucky enough to receive a kidney transplant, that there is a significant risk of recurrent disease in the kidney allograft, and that many patients with IgA nephropathy and a kidney transplant are at risk of losing their kidney and ending up back on dialysis. As you can see, the global burden of IgA nephropathy is significant, and more so in East and Southeast Asia. Despite this global burden of disease, in 2022, we still have severely limited treatment options for our patients with IgA nephropathy. And if I was giving this talk 5 years ago, the outlook for new treatments would not have looked good. There were very few companies looking to develop new drugs for IgA, and very few companies wanting to look at repurposing existing therapies for use in IgA nephropathy. And so why was this? Well, we need to think about how drugs are approved. Traditionally, regulators wanted to see and wanted to measure efficacy of a new therapy in kidney disease by looking at its impact on a doubling of serum creatinine, end-stage kidney disease. And for a rare disease like IgA nephropathy, it is slowly progressive. To use those endpoints, you would have to follow large numbers of patients over a long period of time before you knew whether a drug was effective or not. And quite frankly, those studies were too expensive for pharmaceutical companies to plan and deliver. And this meant that no one was interested in trying to develop new therapies. So what changed? Well, there was an acceptance by regulators that actually, if they were to encourage development of new drugs in rare kidney diseases, they needed to relook at the endpoints that were being used. And this was very much triggered in IgA nephropathy by this analysis you can see here on the left, which showed for the very first time using prospective clinical trial data that an early reduction in proteinuria, and early is between 6 and 12 months after starting a new therapy, was predictive of longer-term kidney function outcome. And here we're talking about kidney function decline 3 to 5 years later. And what you can see from this data is there is a very clear linear relationship between proteinuria reduction and kidney function protection. So the more proteinuria reduction you get early, the greater the long-term kidney function protection. And in fact, that's exactly what we do in clinical practice, isn't it? We treat patients to reduce proteinuria because we strongly believe that that will ultimately protect kidney function. And so data like this and some other data that we analysed as part of the Kidney Health Initiative led to this pivotal paper you can see in front of you here, which said for the very first time that the FDA would accept an early reduction in proteinuria as a reasonably likely surrogate of a drug's future efficacy on long-term kidney health, and could be used as part of an approval program for new therapies in IgA. So what was the impact of this work? Well, the impact of this work was truly transformative in terms of how drug development has been progressing in IgA nephropathy. We've gone from a barren landscape to an absolutely fantastic portfolio of phase 2 and phase 3 studies that are now potentially going to deliver for our patients new therapies targeting different aspects of the pathogenic cascade in IgA nephropathy. And this is what I want to focus my talk on. And before I do that, the first thing I'd like to do is just give you a high-level overview of the pathogenesis of IgA nephropathy, so we can see where these different drugs are acting in patients with IgA and how potentially they could be used in combination because they're targeting different aspects of the pathogenic cascade. And so, as I'm sure you will know, central to the pathogenesis of IgA nephropathy is the formation of circulating immune complexes. These immune complexes have the propensity to deposit within the glomerular mesangium, and once deposited, they can trigger glomerular inflammation and glomerular scarring. We believe that the main substrate for immune complex formation is the presence in the bloodstream of this poorly galactosylated polymeric IgA. And these are IgA molecules that carry very subtle changes to the sugars that are attached to the hinge regions of the IgA molecules. And we believe that this form of IgA is derived from B cells that reside within the mucosal immune system. And the mucosal immune system is that immune system that lines our gastrointestinal, our respiratory, and our genital organs. And we believe that these cells produce this poorly galactosylated polymeric IgA1, which then triggers immune complex formation. And these cells may well reside within the mucosal system, or they may actually have mistrafficked and taken up residence within systemic cells. We don't know that for sure, but we do think that they have originated from the mucosal immune system and are programmed to generate this form of IgA as a natural response to mucosal pathogenic contact. There are a variety of other factors that may influence immune complex formation. There may well be the development of IgG and IgA1 autoantibodies. There may be interactions with IgA receptors. And there may be interactions with IgA antibodies against microbial pathogens that we see that cross-react with this poorly galactosylated. And of course, all of this occurs on a genetic background. And that genetic background not only determines the likelihood of developing IgA nephropathy, but also the likelihood of developing progressive kidney disease if you happen to have IgA nephropathy. And those two are separate different, but the genetic background clearly impacts on both of those aspects of the disease. Now, if we think about what happens when IgA deposits within the glomerular mesangium, we know that that deposition triggers an interaction with mesangial cells. Those mesangial cells become activated, they proliferate, and they secrete a range of pro-inflammatory and pro-fibrotic mediators. These mediators lead to the recruitment into the glomerulus of inflammatory cells, predominantly mononuclear cells, macrophages, and if the inflammation is significant, there is a potential for presence to form and for there to be necrosis and significant glomerularity, although that is far less common in other forms of glomerular. We know that these pro-inflammatory and pro-fibrotic mediators are capable of crossing the glomerular basement membrane, where they can interact directly with podocytes, causing podocyte injury, but also interact with other cells of the network, particularly those cells lining the tubular epithelial cells, where again they can activate these cells and drive tubular interstitial inflammation and fibrosis. And what's becoming increasingly apparent is the IgA complexes not only deposit within the mesangium, but can cross the glomerular basement membrane, where they can directly interact not only with mesangial cells, but also now with podocytes and with proximal tubular epithelial cells, augmenting those signals from the soluble mediators generated by activated mesangial cells to accentuate podocyte injury, glomerular sclerosis, and tubular interstitial inflammation and fibrosis. And of course, all of these processes are amplified by coexistent complement activation. And therefore, we're seeing already that there are some potential therapeutic targets here that could influence the glomerular inflammatory and fibrotic response to mesangial activation. And I'll come back to those later in my talk. Now, the central paradigm for treating IgA nephropathy is to control blood pressure and reduce proteinuria using renin-angiotensin system inhibitors. We've known this for many, many years. Everyone in the audience will be aware of the renin-angiotensin system pathway and how it is important in controlling glomerular dynamics, but also cellular responses to mesangial IgA deposition. What has become apparent, however, over the last decade or so is that there are other biochemical pathways that work in tandem with the renin-angiotensin system and are likely to be equally important in controlling glomerular blood flow, in controlling podocyte biology, and in controlling inflammation and fibrosis. And one of these pathways is the endothelin pathway. We know that endothelin 1 drives a number of different cellular pathways that are linked with cell survival, they're linked with inflammation and angiogenesis, with cell growth and proliferation, and with glomerular blood flow, as you can see here on this, in this figure. And in fact, there is a growing level of evidence that actually by interrupting endothelial signaling, this may well prove to be beneficial in proteinuria kidney disease. And indeed, that is the rationale for the use of sparsentan in IgA nephropathy. Now, sparsentan is an endothelial receptor antagonist combined with an angiotensin type 1 receptor antagonist. So it's essentially two drugs in one. It has been evaluated in the PROTECT trial, and this trial has now completed recruitment, and in fact, the early proteinuria readout has been reported publicly, and this study has met its primary endpoint. Treating patients with sparsentan significantly reduces proteinuria above proteinuria reduction with maximal tolerated dose of renin-angiotensin system inhibitors, suggesting that this pathway may add additional value in terms of renal protection if we are able to block both the renin-angiotensin system and the endothelial receptor antagonist system. And in terms of this effect in other glomerular diseases, we already have evidence that this drug is equally effective in focal and segmental glomerular sclerosis. So you can see here the Duet trial, which has been reported, an early phase study of FSGS, and the Duplex trial, which is a larger phase 3 study of FSGS, has similarly shown a significant anti-proteinuria effect with endothelial receptor. And so this is one of the drugs that I think is likely to become available in the relatively near future, and may well offer us a really useful addition to renin-angiotensin system inhibition in terms of controlling proteinuria. And of course, it doesn't impact the immune system, and therefore potentially has great advantage, particularly in the COVID era of being able to provide our patients with kidney protection, while also not impacting on their ability to deal with pregnant. Another endothelial receptor antagonist that is very interesting is atrasentan, and that is currently being evaluated in the ALIGN global study. And this is recruiting at the moment, and this is a drug that inhibits endothelial receptor activation, does not contain angiotensin receptor blocker action, and therefore is used in combination with any renin-angiotensin system inhibitor or angiotensin receptor blocker. This study is likely to report in the next 24 months, but again shows the intense interest of endothelial receptor antagonism in IgA nephropathy and potentially other forms of proteinuria. Now, I mentioned already that there's a lot of evidence to suggest that the mucosal immune system is the source of the pathogenic IgA that drives the immune complex formation. And I just want to review some of that evidence. So we've known for a long time that if you have episodes of mucosal infection or inflammation, that patients with IgA nephropathy are prone to developing an exacerbation of nephritis marked by visible hematuria within 24 to 48 hours of that mucosal insult. And this has been known for many years. We know that secretory IgA, which is a form of IgA exclusively produced at mucosal surfaces, is increasing the serum of patients with IgA nephropathy. We know that the level of this secretory IgA, a marker of mucosal system IgA production, increases during episodes of mucosal inflammation. We know that the secretory IgA can be found in the mesangial IgA deposits, and that the higher levels of this secretory IgA in the bloodstream, the worse the kidney biopsy features are of diabetes. And so here we have some very clear links between mucosal IgA synthesis and the development and progression of IgA nephropathy. And indeed, we have a lot of evidence to show that the mucosal IgA immune system is overactive in IgA. There are a number of different studies that have looked at the levels in the blood of IgA antibodies against mucosally implanted antigen and have shown that patients with IgA nephropathy have high levels of these IgA antibodies compared to healthy subjects. And indeed, we were interested in looking at this in more detail. And so we looked at the IgA responses against Helicobacter pylori, the bacteria that's associated with the development of peptic ulcer disease, gastric. And we found that in patients with IgA, they had high levels of IgA against Helicobacter pylori. This IgA was polymeric, exactly the same type of IgA that's deposited in the kidneys. And when we looked at the glycosylation, so those sugars of the hinge region, the pattern of IgA1 and glycans on the IgA against Helicobacter pylori again was identical to the IgA that we see deposited in the kidney. Really supporting the idea that mucosal IgA is the source of this pathogenic IgA that ultimately deposits in the kidneys and causes kidney inflammation. And so this has led to a strong focus on the mucosal associated inflammation. Because this is the architecture that generates mucosal IgA. It is very highly organized, consisting of Peyer's patches, which are discrete lymphoid follicles, where antigen is processed and presented to naive B cells and T cells, and where these cells become activated ahead of trafficking to mesenteric lymph nodes before they return to the lamina propria to generate vesicle-treated IgA. And so there's been a lot of interest in understanding the mucosal immune system, if this could potentially be a target for novel therapies to treat IgA nephropathy by switching off the production of mucosal IgA, which ultimately is what we believe drives the immune complex formation. And indeed, this is supported by genetic studies. So here we have the largest meta-GWAS in IgA nephropathy. And when you look at the pathways that are impacted by the genetic risk alleles that were identified, you see that the most enriched pathway is the intestinal immune network for IgA protection, suggesting again that it's mucosal IgA synthesis, particularly within the gut, that is associated with the development of IgA. And so it makes perfect sense to me that we would want to think about targeting the gut, targeting these Peyer's patches and mucosal IgA production as a way of switching off pathogenic IgA synthesis and downstream, therefore, reducing the formation of pathogenic immune complex. And indeed, there is a drug that was designed deliberately to do that, and that is Nefecon. And Nefecon is a particular formulation of the steroid budesonide that is packaged in such a way that the active drug budesonide is only released when the drug hits the terminal ileum. And here, the drug coats the lining of the terminal ileum and impacts directly on the immune cyst cells within the Peyer's patches of the terminal ileum. The terminal ileum has the highest concentration of IgA-producing mucosal cells anywhere in the body. And therefore, the hypothesis was that by targeting this area of the gut, you have the maximal efficacy for reducing pathogenic IgA. And indeed, the phase 2 Nefegan study, which looked at 2 doses of Nefecon against placebo, showed very clearly that by giving a drug that targets the terminal ileum, targets mucosal IgA production, you were able to both reduce proteinuria in patients with IgA nephropathy and stabilize the rate of decline of GFR. And this has been incredibly exciting, and we were lucky enough to have all those samples from the study in our laboratory, because we wanted to see how this drug was able to deliver this effect. And so when we think about secretory IgA, as I've mentioned, this is elevated in IgA nephropathy, it's exclusively produced from mucosal sources. You can see there was a significant reduction after 9 months of treatment with budesonide in the circulating levels of secretory IgA in this study. You can see that actually antibodies against mucosal gut antigens, such as the milk protein casein, were suppressed by Nefecon, whereas the levels of IgA antibodies against a systemic antigen, such as the tetanus toxoid, which we all get as a vaccine, were unaffected, supporting a mucosal-directed route for this drug. We looked at the levels circulating IgA antigen complexes, and we saw a dose-dependent reduction in immune complex, circulating immune complexes with Nefecon. In parallel, in most patients, we saw a suppression of the abnormally glycosylated form of IgA. Again, giving us real confidence that what we were doing was targeting the site that produces the pathogenic IgA. Now, all of this data led to the delivery of design and delivery of the phase 3 NefIgArd study. And I reported the results of the NefIgArd study at the World Congress earlier this year. And this is the result from the first 200 patients treated with Nefecon 16 milligrams in the pivotal phase 3 study. And what you can see here, you can see in these slides, we've got the phase 2 NefIgArd study compared to the phase 3 NefIgArd data. And you can see almost identical reductions in proteinuria and albuminuria with 16 milligrams of Nefecon that we saw in the phase 3 and the phase 2 study. Again, showing that targeting the mucosal immune system had significantly impact on proteinuria in IgA. And what's even more exciting, as again in NefIgArd, as we saw with NefIgArd, this drug led to a protection in kidney function, such that there was no decline in kidney function at 9 months in the NefIgArd patients compared to a 7% reduction in the placebo-treated patients in NefIgArd. This data has now been reviewed by the FDA, and Nefecon, or Tarpeo as it is now known, has become the first ever drug approved by the FDA for the treatment of IgA nephropathy. Now, of course, there are other strategies we could take to treat IgA nephropathy. We know IgA is an antibody produced by B cells. If these autoantibodies are important, they again are B cell derived. And so we could consider a B cell specific therapy, not necessarily concentrating on the mucosa, but targeting B cell specifically. And of course, we know the success stories we have with that in terms of rituximab. And here we've got the typical features of how we see rituximab working in membranous and PLA2R positive membranous. We can see that giving rituximab leads to depletion of peripheral CD20 positive cells. That is followed by a reduction in the autoantibody, the anti-PLA2R autoantibody, which is then followed a little time later by a reduction in proteinuria in these patients with membranous, which is mirrored by an increase in skin arousal and remission of focusing. And this is what we would expect for a pure B-cell-driven autoimmune disease such as membranous. So why not take the same approach with IgA? Well, it has been used. Rituximab has been used in a small phase 2 study in IgA nephropathy. But interestingly, rituximab failed to have the same effect. It did not impact on the abnormally glycosylated form of IgA. It didn't impact on those IgG antibodies that recognize this IgA, and it did not impact on the proteinuria or rate of GFR decline, despite there being exactly the same level of peripheral CD20 positive B-cell depletion. So does this mean that the B-cell approach is unlikely to be effective in IgA? It tells us that IgA is different in terms of its disease pathogenesis to membranous, in terms of perhaps not being as straightforward an autoimmune disease as membranous is. But does it mean we shouldn't be thinking about B cells? Well, I don't think it does. because B cells require a number of other signals to survive and proliferate. And two of those that are most important are BAFF and APRIL. And these signal to B cells through a series of cell surface receptors, the BAFF receptor, TECI, and BCL. And these two chemical signals drive B cell proliferation, B cell maturation, class switch recombination, and B cell suppression. And they're an obvious candidate for therapeutic targeting if we're thinking about stopping B cells from generating pathogenic immunoglobulin. And so when we think about that, there's some very clear evidence that there is dysregulation of that signaling in IgA nephropathy, both from in vitro models and from in vivo models. Levels of BAFF have been associated, or increased levels of BAFF, have been associated with clinical and histological features, and have been associated with a range of different changes within cultured B cells, culture systems that are used to model IgA nephropathy. Similarly, there is a lot of data for dysregulated signaling of APRIL in IgA as well, particularly in relation to the tonsil, but also from genetic studies, suggesting that there are genetic scalarioles within the APRIL gene that are associated not only with the development of IgA nephropathy, but also with the rate of progression of IgA. And so there is clear evidence both for BAFF and APRIL that the signaling through this axis represents a good target for therapeutic intervention. And indeed, there are a number of drugs that have been developed to block BAFF and APRIL signaling. So you can see here we've got Glomerular, which I'm sure you've all heard about. It's now approved for the treatment of lupus nephritis, which is a blocks BAFF signaling. Atacicept, which you can see outlined in red here, blocks both BAFF and APRIL. And then you have these two monoclonal antibodies on the left-hand side that are specifically designed to block APRIL signaling. So you can block APRIL alone, you can block BAFF alone, or you can block both BAFF and APRIL. And indeed, all of these strategies are being evaluated in IgA nephropathy. In terms of atacicept, I presented some data last year looking at the first data in IgA nephropathy, where we showed that treatment with atacicept led to significant reductions in the abnormally glycosylated form of IgA, Gd-IgA. This is the first time ever that we have a drug that is capable of suppressing to this magnitude the abnormal form of IgA. And that reduction was associated with a significant reduction in proteinuria at 24 weeks, really giving exciting proof of concept data that targeting this axis could be a way forward in terms of treating it. Therapeutics is now taking this on, and there is a phase 2 study, the Origin study, which is evaluating atacicept in IgA nephropathy, including a higher dose than was previously tried, to see whether we can get even greater efficacy. Visteria evaluated the monoclonal antibody BIS649, which neutralizes APRIL in a phase 2 study, and the results of this study should be available later this year. Visteria has in fact actually now been acquired by Super Pharmaceuticals, who have recently initiated the Visionary study, which is a phase 3 trial of BIS649, or additive name now, Glomerular, in IgA nephropathy. And Chinook has its own monoclonal antibody, BioMentor-A1, which is targeting APRIL as well. And I presented some early data on the first few patients treated with this approach earlier this year. And again, what we saw when we targeted APRIL only was a substantial reduction in Gd-IgA1, in the abnormally glycosylated form of IgA. And this was associated with a reduction in proteinuria. And very interestingly, it was associated with a reduction in treated patients' serum IgA to activate mesangial cells in culture, suggesting that this drug was somehow altering the circulating IgA complexes and making them less pathogenic. And this is very early data. These studies are still continuing. But I think you'll agree that there's some really strong proof of concept data here that BAFF and APRIL targeting could be a therapeutic option for the future. And finally, I want to talk about complement. As I've already said, complement activation in the glomerulus and in the tubular interstitium amplifies all of the negative effects of IgA deposition and IgA. And we know that the more complement activation we have, either in the kidney or complement activation products we see in the urine, less so in the blood, but the more complement activation that we have, the worse the outcome. And we know that the complement activation is occurring through the lectin pathway and the alternative pathway, but very rarely is it occurring through the classical pathway, because in most cases of IgA nephropathy, C1q is usually not found on kidney biopsy. And so, what evidence do we have that inhibiting complement is likely to be beneficial? Well, of course, this only became possible recently with the discovery and implementation of eculizumab, which is a monoclonal antibody against C5. There were a few case reports showing the proof of concept that blocking complement activation can impact on the progression of IgA. Of course, eculizumab is very expensive and not a viable treatment option in the long term for most patients with IgA nephropathy, and it comes at a risk. It comes with a significant risk for encapsulated organism infection, particularly Neisseria meningococci. So, what other options do we have? Well, excitingly, we have a number of different potential therapeutic approaches currently being evaluated for IgA nephropathy. The first of these is a really interesting compound called cemdisiran, which is blocking C5. What's interesting about cemdisiran is that it is an antisense oligonucleotide. And I just want to draw you back to that one of those slides I showed you earlier, where no pharmaceutical company was interested in IgA nephropathy. Yet in 2021, we now have monoclonal antibodies, we have small molecules, we have traditional drugs like trazodone, but we also now have molecular approaches in terms of antisense oligonucleotides being evaluated in IgA nephropathy. And that really shows what an exciting time we're in terms of novel therapeutics. And so cemdisiran is an antisense oligonucleotide against C5, and it's designed to target the liver, because the oligonucleotide has a sugar tail, which targets the asialoglycoprotein receptor of the liver, meaning that this drug is selectively taken up in the liver and blocks the liver production of C5. This study has completed recruitment, and we're really interested to see what the results of this study will be over the next 12 months. In terms of other therapies, and no doubt you will have heard about avacopan, which is a soluble C5a receptor antagonist. It's recently been approved by the FDA for the treatment of ANCA-associated vasculitis. There is a small proof of concept study in IgA nephropathy. I'm not sure whether this can be evaluated in any larger scale study, I'm afraid. But again, this shows the potential for avacopan as an add-on therapy in IgA disease. Pegcetacoplan is target C3. There's been data presented that have looked at C3 glomerulopathy and absence of electron in the blood and urine. And IgA nephropathy was included in this basket trial, although I've seen no data from the IgA nephropathy patients. So we'll have to wait to see that, as to whether this therapy offers an advantage over the other cocktail therapies being tried. There are more targeted approaches to inhibit the complex. Here is an approach to target just the lectin pathway. Now, the key protease of the lectin pathway is MASP2, and we know that the more lectin pathway activation, the worse the outcome in IgA nephropathy. We know IgA is capable of activating the lectin pathway directly, and we know that changes in mesangial C4d deposition are associated with lectin pathway activation, because we don't see C1q and therefore the C4 degeneration must have come from the left-hand side. There's a monoclonal antibody, narsoplimab, which has been designed to specifically inhibit MASP2, and we have presented some early phase 2 data showing efficacy of narsoplimab in a small cohort of patients with IgA. And this data was strong enough to stimulate a phase 3 registration study, and that's the Artemis IgAN study, and this is recruiting globally and is well on the way to finishing recruitment. And here we will have the largest ever study of complement inhibition in IgA. And this, as I say, offers a targeted approach to the lectin pathway while leaving the classical and the alternative pathways. But as I said, the alternative pathway is also important in IgA. And we know that from a range of studies, particularly the genetic studies, and particularly genetic mutations and changes in the regulators of the alternative pathway in terms of complex factor H related proteins, particularly CFH1 and 5. And therefore the alternative pathway is yet another complement target for EPA. And indeed there are small molecule inhibitors of both factor D and factor B. There are 2 studies currently ongoing looking at inhibition of factor B, one using the drug iptacopan and one using another antisense oligonucleotide, Ionis factor B LRX. I presented the early data from the phase 2 study of iptacopan, and this was the 12-week endpoint analysis looking at proteinuria reduction with alternative pathway inhibition in IgA. And the exciting thing here was that inhibiting the alternative pathway did indeed reduce proteinuria in a dose-dependent fashion. And perhaps even more exciting was that we saw parallel reductions in urinary C5b-9 excretion in the urine, suggesting that this drug was truly impacting on complement activation within the kidney, reducing the excretion of the terminal complement pathway components within the urine. This work has been taken forward into a phase 3 registration study, which is now recruiting the Applause study, and this is likely to report in the next 24 months or so. And again, will be one of the largest studies of complement inhibition in IgA. As I've already mentioned, the Ionis study is a study of another antisense oligonucleotide. But actually, this study is a much smaller open-label study providing proof of concept. And again, my understanding is that this study is finished recruitment, but we have not seen any results. And so where are we going to be in the next 5 to 10 years? Well, I hope I've convinced you that the future, having been looked awful 5 years ago, is now incredibly exciting in Asia. We are going to have the opportunity to have multiple targeted therapies available for our patients. We are going to be able to give them non-immune mediated therapies, endocrine receptor antagonists in combination with renin-angiotensin system inhibitors. I haven't had the chance to touch on SGLT2 inhibitors, but I'm sure you are aware of the DAPA-CKD study and that subset of IgA nephropathy patients included in that. I think there are some drawbacks to that study, but SGLT2 inhibitors may well become part and parcel of our general supportive care of the patient with that. I've spoken about the ability to target the production of pathogenic bacteria, either by targeting specifically the mucosal immune system with Metacon, or targeting B cells directly through inhibiting BAFF and APRIL support. And at the other end of the spectrum, we can turn off the inflammatory response within the kidneys to that mesangial IgA deposition by blocking complement activation. And the really exciting thing for me is that I think we can be using these drugs in combination to switch off the production of pathogenic IgA and then to switch off the inflammation downstream to protect the kidney in the here and now while we're waiting for that pathogenic IgA to stop being produced, those immune complexes to clear from the circulation, and for the kidney to have time to remember. So I'm going to stop there. It's been a real pleasure. I'd like to, I look forward to questions, and I hope to welcome you to Leicester at some point in the future. Here's the team in Leicester. So thank you very much. And I look forward to questions. Thank you. Bye-bye.
I don't think we can take up the question and comment. This is a recorded lecture. Okay. Any comment from the audience? Any question from audience?
Yeah, Dr. Jonathan, you are there?
Yes, can you see and hear me?
Yeah, sure, no problem. The IgA nephropathy is very interesting disease and always it focuses us to the decision making in treatments. I have a question for you. The patient with IgA nephropathy, the creatinine of 2 and the proteinuria of 4 grams, what's your advice in that case? And what's the role of MMF? It has not been there in use, but now it's coming again. Vis-a-vis other immunosuppressive drugs, and of course, dapagliflozin.
Yeah, it's a really good question. And I think if you've got 4 grams of proteinuria, I guess the key question is how much of that is driven by fixed scarring and how much is driven by active inflammation, because that determines what you're going to do.
IFTA score is 25%, and I can't remember the next scoring as such, but it's no presence. Otherwise, proteinuria around 5 grams and creatinine around 2.5.
So if this is all scarred, if this is lots of segmental sclerosis and tubular interstitial fibrosis, if it was my patient, I would be managed them with supportive care. If there was lots of inflammation, then again, this is someone I think would benefit from the new treatments that I've spoken about. I don't use MMF and prednisolone. I know Cecina, who I think may well be talking after this session, has the GRACE cohort, and MMF and prednisolone is widely used in India. And I think this speaks to the fact that actually Indian IgA nephropathy, from my experience working with Cecina, is very different to the IgA nephropathy I see in Leicester. And I don't think we can necessarily extrapolate what we know about Caucasian IgA to what we see in India or other areas of East and Southeast Asia. So I think if you've got inflammatory lesions, then the drugs we have available at the moment are steroids and MMF. And I think until we have these new therapies online, we don't have anything else to give our patients. But hopefully in the future, we may well have complement inhibitors, and we may well have those other therapies such as Tarpeyo that I talked about. But I think at the moment, the only real option we have to treat that inflammation is, if you want to give treatment, is to give prednisolone and potentially MMF.
Question was regarding immunosuppressive drugs, cyclophosphamide versus mycophenolate. What is your
So cyclophosphamide, there's evidence for in disease which is rapidly progressing and often has crescents. If there's no crescents, I really wouldn't use cyclophosphamide in IgA nephropathy. I would only use it in the setting of a rapidly progressive glomerulonephritis.
So I just wanted to know, the trials you've mentioned on IgA nephropathy, many of them do not have SGLT2 inhibitors as standard of care. So most of the patients are on RAS blockade. Do you think these trials, SGLT2, have enough evidence to merit they also as standard of care plus RAS blockers before we put the patients on these newer drugs? That's a first question. It's a kindly answer that.
So a lot of the trials are now including people on SGLT2 inhibitors to see whether they add value above SGLT2 inhibitors. I think I'm waiting for the EMPA kidney study to report. to really corroborate what we saw in DAPA-CKD before I start using it in every patient of mine with IgA. But I think all the new studies are starting to think about having patients on SGLT2 inhibitors and then adding therapy to it to see if it improves outcomes.
The other question is, in India, we do not do biopsy for asymptomatic hematuria, proteinuria. We don't have a universal screening program in most of the centers. So most of the patients who reach the nephrologist have the GFR between 30 to 45 or even sometimes less than 30. So do you think these newer drugs would be effective if used between 20 to 30 GFR as well? And should those patients be a part of these trials, or maybe from 15 to 30 as well? Because we have a lot of patients of IgA coming to us in that state of GFR.
So most of the trials cut off at GFR of 30. They do include some patients between GFRs of 20 and 30. So we will have some information on that level. I think when you're getting down to a GFR of 15, if that's associated with lots and lots of scarring, I really wouldn't put my patients at risk of having immunosuppression. I would just do the basics, and I would be planning for dialysis. I don't think we've got any drugs that will help when the GFR is that low, unfortunately, unless that GFR is low because of inflammation rather than scarring. So we will have some information about that 20 to 30 group, and we'll see whether these drugs work. And certainly, I've been involved in some data with the narsoplimab, the lectin pathway inhibitor, and that does seem to have an effect even between the 20 and 30 group. But we're not going to have great amounts of data. And below 20, I don't think we'll have any data, unfortunately.
Thank you.
Dr. Bhalla.
Excellent lecture, Dr. Jari. My comment is regarding the use of this newer trial drug. We are part of the study, this Vistera 649 trial, and we have seen very promising results as far as proteinuria is concerned and maintaining GFR is concerned. So maybe that future is going to be more of target-oriented therapies like BAFF inhibitor or APRIL inhibitor, or as you mentioned about other various complement inhibitors. And whatever we are doing now is like steroids, MMF, all these are quite actually non-specific treatments.
I completely agree. I think the data with the APRIL inhibitors is really interesting, and it's only early, and we're waiting for that Vistera study to read out. But I think Vistera has now been bought by Otsuka, and the phase 3 study is already rolling out. So they're clearly confident in the data, but I haven't seen it yet. But I think the data from Chinook, the data on itacicept is really exciting. So yeah, I agree with you. I think we will hopefully be having drugs that mean we can avoid steroids and have a really good response.
We are going to start phase 3 study soon in next 1 or 2 months actually, in India.
It's fantastic. So one of the things I think about the phase 3 studies is if we can include as many countries as possible, we can start understanding whether the disease is really different. So we can look at how Indian patients respond to this treatment compared to the patients I see in Leicester or the patients in the US or Europe. And I think that's going to really help us understand what's going on in IgA.
If you are here for the next 1 hour, you will find Indian study, Indian presentation of IgA nephropathy, which is actually totally different from the West.
Thank you. Thank you.
I just wanted to know, we are putting these patients on different trials which act on different pathogenetic mechanisms of IgA. So would it make sense to do a biomarker first and decide which patient to put on which drug? For example, the BAMF ones on that, the APRIL ones on those drugs, because so many drugs we are using for IgA without testing the biomarker. Do you think it's a good thing to do?
Absolutely. So I think that's a great question, because it is absolutely what we need. You imagine we've got MMF and steroids now. In 5 years, we could have about 10 different drugs to choose from. How are we going to decide which patient for which drug at which time? And we desperately need biomarkers. So in tandem with all these clinical studies that are looking at the drug, how the effect of the drug, we're collecting together blood and urine samples that allow us to do exactly that, identify biomarkers that will allow us to direct the drugs to the right patients. We don't have them yet, but I think that's going to come in the next 5 to 10 years as these therapies come through.
So at the same time, all the trials can collect biomarkers studying all the pathways, because what's happening in Vistara, we are looking at the APRIL-related biomarkers. In the other study, we are looking at that biomarker only. So so many trials are going on. So actually, we can have biomarkers collected, the complete, the panel we have for all the trials.
Absolutely. So they're collecting blood and urine. Of course, companies don't like talking to one another, so it's not going to be they're going to share their data necessarily easily. But they've all been collected with enough samples to do all the things you've talked about.
Thank you.
Thank you very much, Professor Barrett, for this excellent talk and giving us a big hope for IgA nephropathy in future. Thanks you once again, and we'll close the session here. Thank you.
Can I just say thank you very much for inviting me, and it's a real shame I can't be with my friends in Lucknow now, but hopefully next year.
Yeah, we also hope that you can come again.
Bye-bye.
Bye. Thank you.
Thank you, sir, for that wonderful lecture from molecular to clinical level. We thank dignitaries for chairing the session. We now move on to the next session, center-specific experience of IgA nephropathy from India. For this, I invite the first speaker, Dr. Soumita Bagchi from AIIMS, New Delhi. To chair this session, may I invite Professor K.L. Gupta, sir, former professor and HOD, Department of Nephrology, PGMR, Chandigarh. Dr. D.V.S. Somayajulu, consultant nephrologist, Kakinada, Andhra Pradesh. Dr. Namrata Rao, associate professor, Department of Nephrology, RML, Lucknow. Dr. Nitin Bajpai, associate professor, Department of Nephrology, AIIMS, Jodhpur. And Dr. Amol Bhawane, assistant professor, Department of Nephrology, AIIMS, Nagpur.
Well, at the outset, for having given us the opportunity to be here. As a matter of fact, it's in this CME and the Foundation Day. My association with Dr. Vijay Kher, Dr. R.K. Sharma, Hamid, Narayan, other colleagues, I've been really fascinated with the progress Institute has made over the years. I remember the day when Dr. Vijay Kher was mentioning one day in London in the same conference. He told us what facilities they had. I felt very jealous. I got 10,000 from Institute for this international conference that he had from full sponsored money. Well, that's just side part of it, but it is a great honor to be visiting here. And now we come to the session. We had an excellent delivery by Dr. Jonathan Barrett on the pathogenesis, on the treatment, current and upcoming treatment. And of course, let's have now Indian experience. I will ask my co-chair to introduce the first speaker.
We'll be now having the various experiences from some of the large institutes of our country. The first to start with will be from Dr. Soumita Bagchi, who is a consultant in All India Institute of Medical Sciences, AIIMS, and she will be speaking on her experience of IgA nephropathy from the northern part of our country. Over to you, ma'am.
Thank you for having me here, and I'm going to talk about what we have seen and what we have been dealing with IgA in the last few years in the AIIMS cohort. So how common is IgA to begin with? And we looked at a 10-year data biopsy audit from our center a few years back. This is 2006 to 16, and out of 3,000 biopsies, 88% were glomerular diseases, and of which 10.4% was IgA nephropathy. So it was not the most common glomerular disease as is we had minimal change first, FSGS second, membranous was third, and then IgA was the fourth most common. The prevalence, I think, would be increasing as slightly higher if you look at the data now, because our immunofluorescence data was a bit sketchy before 2010. 2010 onwards, we also have our pathologists also do IF and paraffin to supplement the IF, routine IF data when required. So I think the IgA prevalence will be slightly higher if we look at it now. We looked at a cohort recently in order to examine the IgA nephropathy prediction tool, which was given by the International IgA Nephropathy Network a couple of years back. It was published in JAMA in 2019. So this is what we did. We screened 483 patients from 2013 to 20, and we included 328 patients as per the inclusion criteria. We excluded 12 patients where the baseline data was missing, which was required for the prediction tool, and finally 316 patients were analyzed. So what we wanted to do is we wanted to see whether the International IgA Nephropathy Network prediction tool, which recently KDIGO said should be used for prognosticating patients with IgA, actually worked in our patients. The reason we did that because this is a tool, it's actually a calculator which you can use in clinical practice. It's available online and it has two models, one with and without weights. Baseline data required is age at the time of biopsy, the eGFR, the mean arterial pressure, the proteinuria, and whether the patients were on ACE inhibitors or immunosuppression at the time of the biopsy, and the biopsy mesh histological score. Now, the cohort used for developing and validating this prediction tool mainly comprised of Europeans, North Americans, the Chinese, and the Japanese population. So there were no South Asians in this cohort, and that is why we wanted to know whether it worked in Indian patients. So this is the tool, and what it does is it classifies patients into 4 risk groups: low risk, intermediate, higher, and highest risk groups, and then gives their 5-year risk of the primary outcome, which is doubling of 50% decline in estimated GFR or progression to end-stage renal disease. So if you look at the AIMS cohort, which had 316 patients, we compared it with the original derivation as well as the validation cohorts, which were of course much larger. What is prominent is that our patients had higher proteinuria. The baseline GFR at the time of presentation was lower, so we had more proteinuric patients with more chronicity on examination. Histologically, we had a significantly higher mesangial hypercellularity. We had 70% M1 lesions, but our endocapillary lesions were lower, which was only 9.2%. Surprisingly, because of the proteinuria and the eGFR, you would expect that the T1, T2 lesions would be significantly higher, it was higher, but it was not that significantly different. We had around 16% crescents in our cohort. This would be again higher because we excluded patients with eGFR less than 15 for analysis. Crescents were not examined in the original cohort. The use of ACE inhibitors and ARBs and immunosuppression prior to biopsy was not very significantly different. We had a shorter follow-up, and we had much higher primary outcomes. Even despite a follow-up of only 2.8 years, we had a primary outcome was achieved in 27% patients, which was 18% and 19% in the original cohort. So this is what happened when we tried to validate the tool in our patients. It was good in separating the patients into the 4 risk groups. Like it correctly does that. So when they say that the patient is low risk, it has a better survival than the patients who have intermediate, higher, or the highest risk. And this worked with both the models. So it had good discriminant ability in our patients. But when we look at the survival, the red line is the model without the race, and the blue line is the model with race. And the black line shows what we actually see in our patients. So what we observed in our cohort was significantly worse survival than what the tool predicted in our patients. And this is not just for the high-risk patients. It is true for both the low risk and intermediate. Of course, the gradient of difference increases as the risk group increases, but it is seen across all the risk groups. And this is the original study, and it shows that the observed and the predicted risk in all the 4 risk groups is very similar. Well, if you see our patients, there is significant separation between what is observed and what is predicted by the formula in all the 4 risk groups. And this actually says that, there is all this theory that Indians, do they really have severe IgA, or do we diagnose them late? But if you see here, patients who are low risk, as per the formula, also do worse compared to patients who are low risk in other populations. So we do actually seem to have severe disease. So we published this data recently, and it is basically showed that it has a good concordance statistic, good R2D, suggesting that it is good at discriminating patients, showing who is intermediate risk, high risk, and low risk, but it does not, it underestimates the disease survival significantly. So as of now, we should not be using this prediction tool in Indian patients. And since we had a shorter follow-up of 2.8 years, we tried the entire exercise at 2.8 years as well as at 5 years. And in both the situations, it did not work very well in our patients. Now coming to biomarkers, unfortunately, other than membranous, we really have not had much luck with biomarkers in glomerular diseases. And even today, despite so much work and so many publications being around, we still use proteinuria, hypertension, and estimated GFR for deciding treatment. To some extent, we use the MES score. There have been many biomarkers like serum IgA, IgA-C3 ratio, the secretory IgA, and the galactose deficient IgA levels and antibodies to them, which have been proposed. So we did a small study a few years back. It was a case control study looking at baseline serum galactose deficient IgA levels in patients with IgA nephropathy and whether it can help us differentiate them from other diseases. So what we did is we took 130 adult primary IgA nephropathy patients. Those were the cases. For controls, we took 60 patients with biopsy-proven non-IgA disease. They were minimal change, membranous, and lupus. And we took 50 healthy volunteers. We excluded patients with secondary IgA. We measured serum galactose deficient IgA in the baseline serum sample. So we have a biorepository in AIMS from 2013 onwards. So we store all samples for all biopsy-proven kidney diseases at the time of biopsy, and we use those samples for this study. Measuring galactose deficient IgA had been difficult in 2015 because it was a lectin-based assay, difficult to do. In 2015, the Japanese group came up with a simpler ELISA kit which uses the KM55 antibody against Gd-IgA. It can be done in serum as well as on tissue by immunohistochemistry, and we use this. As you can see, the galactose deficient IgA levels are significantly higher in IgA patients compared to non-IgA and healthy controls. But the sensitivity and the specificity was not very good. It was around 75% when comparing IgA with healthy controls as well as with non-IgA patients. The positive predictive value was around 87.8% against healthy controls and around 86% against non-IgA disease. Baseline levels did not correlate with the histology. It also did not correlate with the estimated GFR and the urine protein at baseline. Interestingly, patients with higher galactose deficient IgA levels actually had poorer renal survival at 12 months as well as 48 months, but we did not find a significance, probably because the study was not designed to look at outcomes. And if you take a larger cohort and have a better follow-up, maybe it may come out as a significant biomarker for prognostication. But as of now, at least based on the study, we don't think we can use it as a biomarker, a routine biomarker in clinical practice. A pathologist did a small study doing immunohistochemistry for galactose deficient IgA1, and it is actually very useful for differentiating patients who have IgA nephropathy from patients where there is an IgA co-localization like IgA MPGN or IgA dominant infection related GN. And this is now actually used in routine practice in pathology in our setup. Whenever there is, our pathologists do galactose deficient IgA1 for all IgAs currently, especially whenever there is a doubt. Coming to treatment, we set up the prospective IgA cohort a few years back. It is a very selective cohort which includes patients who have proteinuria more than 1 gram, eGFR more than 30 at the time of biopsy, and have never received immunosuppression or AC inhibitors and ARB. They were started a supportive treatment for 6 months, and they were given uniform treatment. Everyone got Ramipril. If they did not tolerate it, they got Losartan. Strict blood pressure control, and we looked at remission rates at 6 months. And what we found is that at 3 months, around 36% patients achieved remission. Most of them were partial remission. But if you progress, extended the therapy to 6 months with close monitoring, the remission rates went up to 50%, more than 50%. So good RAS blockade, good blood pressure control can actually achieve remission rates without using immunosuppression if you keep a close watch on these patients. There is a cohort of IgA who will respond and you don't need to jump to immunosuppression. So the thing is, you need to optimize the dose. Almost more than 93% patients receive at least 50% of maximal dose of ACE inhibitors. 60% receive 100% dose. And what is interesting is always ACE inhibitor ARB trials have this, that there is a difference in the blood pressure control achieved in the control group, and that may be one of the reasons that affecting the outcome. But in our patients, those who did not achieve remission and those who did had similar blood pressure control, which shows that whatever the effect has been achieved is probably because of the RAS blockade. So this will be published last year, and in the approach cohort, we found that patients who obviously had severe disease like lower baseline EGFR and serum albumin levels and higher proteinuria were less likely to respond to ACE inhibitors. Physiologically, E1 lesions and high chronicity did not do well. Surprisingly, 9% of these patients had crescents, C1 crescents, and despite that, crescents were not a factor which affected remission rate. So if you have C1 lesions, stable GFR, you can start with ACE inhibitors and ARBs instead of jumping to immunosuppression, provided you keep a close watch on these patients. This is just a brief data of hydroxychloroquine. We started using it after the RCT came from China in AJKD in 2019. And we published 37 patients recently who had persistent proteinuria and EGFR more than 30, despite 6 months of supportive therapy. And we got a good response. More than half of them responded, and none of them had a progression of disease within that 6-month period. Those who had achieved remission had lower proteinuria, so may not be a good idea to use if it have higher proteinuria. And they did relapse. Some of them did relapse when the treatment was discontinued. So there may be a case, if it works, it may be used long term as we use it in lupus nephritis. It is a drug which is well tolerated. Another thought is that if you have IgA nephropathy patients who are pregnant where you need to discontinue the ACE inhibitors and ARBs, you may think of starting the patient on HCQ because it is safe in pregnancy and it can help you control the proteinuria. We are currently doing a RCT which we started just late last year, comparing HCQ with supportive therapy. Dr. Arpita is here. She's been a great help for the trial. She's been a great contributor. So we hope the trial will give us a better idea of whom we can target with HCQ. I don't have data on immunosuppression. We do use it obviously because half of our patients do not respond to all these therapies. The thing is that IgA is not like membranous or minimal change that you have discrete episodes of remission and relapse. It is a smoldering disease. There is an aberrant mucosal IgA production, and with the number of intercurrent infections we have in our country, the IgA production is going to continue. So giving immunosuppression long term may be an issue, especially with the infection disease burden, and we may need other modulating therapies. Dapagliflozin, of course, is one of the things which is being evaluated for that, and as we heard earlier, most of the trials are including it, so that may be another option. So to summarize, from our experience at AIMS, we do seem to have a severe disease phenotype. We have more M1, less E1, and significant chronicity on biopsy. With the current data, we should not be using the international prediction tool suggested by KDIGO. And we should, I think, optimize supportive treatment before jumping to immunosuppression. That is something very important. I mean, giving maximum doses of ACE inhibitors, monitoring them closely, you can get a better outcome than just giving steroids and MMF. There is a role of steroids and MMF in the patients who do not respond, but selecting that cohort judiciously is something we should focus on. Thank you. I wanted to thank the Department of Pathology and Lab Medicine and all our faculty, all the patients of IgA, and especially the senior residents who work with us because they are a huge contributor to this study. Without their help, we cannot follow this cohort, and a big thanks to all of them.
Dr. Somita, thanks for this nice, crisp and evidence-based presentation. Now, house is open for questions.
Okay. Thank you, Somita. After hearing what is experienced from AIMS, it's our pleasure to have Dr. Namrata Rao as a professor of nephrology at RMN Hospital to discuss the experience from PJ Chandigarh. What she's going to discuss was to be presented by Dr. Raja, and he had to leave for airport some because of delay in the session. And the work is based on study by Dr. Parvakar, who was contemporary of Dr. Namata Rao, and he's done cases under me and Dr. Raja. And of course, it was extended later. So Dr. Namata will tell us what we observed in PGI and what has been. Namata, can you start? Okay.
Thank you, sir, for the kind introduction. The data that has been presented here presents an analysis of data collected between 2015 and 2019 from the Department of Nephrology and Histopathology, PJ Chandigarh. LM included any biopsy pattern, and IF included isolated or IgA dominant deposits with an age group of more than 15 years. The sample size was 218 patients. Demographic details, the mean age of patients included in the study was 34 years, and up to 55.5% of patients were in the age group of 30 to 60, with the majority being male up to 154. Majority of patients were hypertensive, and 56% of patients presented with resistant hypertension, and up to 3 medications were used for the control of hypertension in patients at presentation up to 3 weeks. And 11% of patients had malignant hypertension. The mean systolic blood pressure was 144 and a mean diastolic pressure of 89.5. Coming to the clinical presentation, 12.8% of patients presented as nephrotic syndrome. Up to 8% of patients had nephritic syndrome or nephrotonephritic syndrome at presentation. And presentation as chronic kidney disease and acute kidney disease was seen in 66% of patients, which is the majority presentation here. Presentation as normal sized kidneys with TKD was 7.3%, and biopsies done for abnormal asymptomatic kidney abnormalities was 6.12%, and with for gross hematuria up to 8.2%. The median serum creatinine was 2.13 milligrams per deciliter, translating to an eGFR of 34.1 ml per minute. The proteinuria was up to 2.7 grams per day. Looking at the Oxford CMS score, M1 lesions were predominant, like my previous speaker highlighted from her AIMS experience, whereas majority of the others were in the 0 category. Coming on to treatment, this includes a median duration of follow-up of around 19 months, and it can be seen that up to 30% of patients received ACE-ARBs, 4.5% of patients were on dapagliflozin, especially in the latter years, and up to 30% of patients received steroids, and 4.6% of patients were on MMF. Up to 5.5% of patients received a combination of cyclophosphamide and glucocorticoids. When we look at ESKD as an outcome, it could be seen that age, hemoglobin, serum creatinine, as well as systolic blood pressure were significant predictors of ESKD as an outcome. And when looking at biopsy features, the presence of mesangial hypercellularity and IFTA of more than 25%, presence of any crescents or extracapillary proliferation, as well as glomerular sclerosis of more than 20% were associated with the outcome of ESKD. This has been wrongly picturized, but the lack of IFTA, as in like IFTA of less than 25%, was associated with an odds ratio of 0.026, and the lack of or the absence of any extracapillary proliferation was associated with an odds ratio of 0.376. Coming on to a separate analysis, which was done in patients of recently glomerulonephritis between the years of 2011 to 19. IgA remained the most common cause of presenting GN in this group, and this includes an analysis of 88 patients. Coming on to the demographic details of this presenting GN cohort, the mean age was 28.9 years, with again a male-female ratio of 67:21. Again, they presented with a rather high creatinine of 6.32 milligrams per deciliter, a proteinuria of around 2.2 grams, serum albumin up to 3.3 grams per deciliter, and microscopic hematuria was there in up to 74.5% of patients. Coming on to their clinical presentation as nephrotic syndrome was seen in 6.7%, Presentation as acute kidney disease was predictably at about 56%, and presentation as normal-sized kidneys with end-stage renal failure was 33%, and with asymptomatic urinary abnormalities was much lower at 3.3%. Coming on to therapies that they were treated with, a combination of cyclophosphamide and glucocorticoids was used in 25%. Just corticosteroids were treated in almost 50% of patients, and those with advanced DIPTA and receiving conservative therapy were up to 27% of patients. When outcomes were looked at the end of 12 months in this cohort, about 63% of patients were those who progressed on to have ESKD, whereas the complete and partial
see the low.
Greetings to everyone, and thank you, Dr. Narayan and the STPGI team for giving us this opportunity. So this is the sector-specific update from CMC The Law. Homage to John Berger, who's founded the diagnosis of IgA in 1968. The insights that I'm giving here are from a prospective cohort. So this is not the entire data that we have in CMC. This is a prospective cohort, the Grace IgNF cohort, which has been going on since 2015, and it represents the South Asian region. So we have a derivation cohort which recruited 2001 patients, and they had a 3-year longitudinal follow-up which was over in September 2020 and is continuing their ongoing follow-up. We also have a validation cohort which is ongoing recruitment and has recruited almost 250 patients till now. So this is a template that was shared by Dr. Narayan for us to populate, and I've just populated the template with the demographic details of 450 patients, which shows a mean age of 36. a male to female ratio of 2.1. Hypertensives were 84%. More than 2 drugs were used in 54% of patients. The mean serum creatinine was 2.1, eGFR was 36 median. The median proteinuria was 1.9 gram per day, and nephrotic range proteinuria was remaining 34%. Most patients were from South, Central, East, and Northeast regions of India, along with the neighboring countries. So this is the categorization of the patients in the various GFR categories, and their presentation in the various GFR categories, and the lead time to renal biopsy from the first presenting symptom. So the longest time was for the symptom of hypertension. So this tells us that IgA smolders subclinically in South Asian IgM patients before developing symptoms, and emphasizes the need for universal targeted screening, at least in newly diagnosed young hypertensives in this region. Again, this is a picture which is stratified according to the GFR as well as according to the proteinuria, and shows you the various presentation, the commonest being hypertension with or without pleural edema. The recurrent visible hematuria associated with synpharyngitic illness was uncommon, and not a very infrequent presentation was young people presenting with visual disturbance and then going on to have a diagnosis of hypertension. So a simple screening strategy like urine dipstick is likely to be a good public measure. Again, nephrotic range proteinuria was 34% without significant hypoalbuminemia. It was in our cohort. This cohort is it has avoided all patients that are less than 15 ml per minute GFR. It has only included those who have more than 15 ml per GFR. This is another template that was shared by Dr. Narayan for us to populate. And ours, we had lesser mesangial hypercellularity, but higher endocapillary hypercellularity. There was significant segmental sclerosis, and moderate to severe tubular atrophy was seen in 78%. Presence, again, this is not a RPGN cohort. This is a cohort which has more than 15 ml GFR, so the presence are low. And that's the immunofluorescence pattern. This shows a correlation of the various MES scores with mean arterial pressure, the 24-hour urine protein, as well as the eGFR, the S1 and S0 and S1 score, as well as the T scores. We noticed that even incidentally detected mild IgAN had significant fibrotic lesions. eGFR more than 60 ml per minute and 24-hour urine protein less than 1 gram had 38% S1 lesions and 19% T1 and T2 lesions. And when the proteinuria was more than 3 grams per day, even in a higher eGFR group, there were significant chronic lesions. So this helps us, let us wonder whether it is a low nephron number which is causing this, or a specific fibrotic response to mesangial IgA deposition in South Asians. There's another template again requested by STPGI, and we populated it with the treatment approaches. The supportive treatment in this cohort, there were about 67% who received ACARBs, about 60% received fish oil. Statins are given only if there is an indication like dyslipidemia. Antiplatelets again are given only if there are any other compelling indications. SGLT2 inhibitors are not being used as standard of care now, so it's less than 10%, and hardly anybody uses dual RAS blockade in our center. Immunosuppression wise, we had a very high risk cohort, and they all received, most of them, 70% of them received steroids, 2 milligram per kg alternate day, which was tapered over 6 months. So this is the longitudinal outcome at 3 months, which shows a partial remission of 78%, complete remission of 34%. There was a significant rapid progression seen in 39% of patients over 3 years, and composite outcome, which was defined as more than 50 ml decline in eGFR, death, a dialysis or transplant, was seen in 37% of patients in this cohort. So this it's not a true validation study, but we looked at the prediction risk, the IgAN prediction risk, and stratified the patients in ascending order of their risk. And the red bars indicate the actual outcome, so which shows that there is an underestimation of this equation in our population. This slide shows the renal survival over 3 years. Again, the rate of decline in eGFR, especially more than 5 ml per minute per year, was a very significant predictor for composite outcome. And at 1 year, it had an AUC curve of 0.8 with a sensitivity of 86% and a specificity of 90% for predicting composite outcome. This is again another slide which has stratified the outcomes based on eGFR and proteinuria. The green are those who did not have a bad outcome, and the red are those who had worse outcomes. It shows that higher baseline proteinuria for any given level of eGFR was associated with rapid progression. This is a slide which shows the relationship between proteinuria and outcomes. Again, in bad outcome group, that is the composite outcome group, the percentage of patients who had remission to proteinuria was significantly less. And if you see the bottom graph, it tells you that having a sustained proteinuria of more than 1 gram per day, more than at 1 year, was a significant predictor of composite outcome. Another interesting thing that we noticed was regarding albumin. Though most of our cohort did not have severe hypoalbuminemia as we see in other glomerular diseases, but even the fact that they had less than 4, that is between 3.5 to 4 milligrams per deciliter of albumin, which was persistent at 6 months, predicted a composite outcome. This was again one more template that was requested for this presentation. And this is not related to this cohort because this cohort does not recruit precentric IgA, but this is the usual treatment that we give in our center for all precentric IgA. They are treated as vasculitis with pulse steroids and cyclophosphamide. So some of the insights that we have into the pathobiology of South Asian IgA, which is very preliminary data right now, and some of them are being reviewed in journals. This is the secretory IgA level between IgA nephropathy, disease control, and healthy control, which shows that there's significantly more secretory IgA in the IgA nephropathy patients compared to disease control and healthy controls. But they did not associate with any clinical or histopath variables at baseline. And also, they did not associate with any of the longitudinal outcomes at 3 years. Again, looking at serum C3, lower serum C3 was associated significantly with composite outcome at 3 years, but was not a good predictor in the Cox proportional hazards model. Higher serum C4, again, though it associated with CO with composite outcome, did not come as a significant predictor in the Cox proportional hazards model. Coming to mesangial C3 deposition, again, did not show any significant outcomes with any significant associations with longitudinal outcome. C3d deposition in the kidney biopsy tissue C4d was increased compared to DC, again did not associate with longitudinal outcomes. The same with C3d, there was significant univariate association with composite outcome, but not in the multivariate Cox proportional hazards model. So this is, we had measured serum galactose deficient IgA1, and there was no significant difference between IgA nephropathy, disease control, or healthy control. But we did notice that over time, the serum galactose deficient IgA1, if it remained persistently high, it predicted composite outcome, especially the ratio of serum Gd-IgA1 and serum IgA was much more significant as a predictor of composite outcome over 3 years. So more than serum galactose deficient IgA1 alone, it's the proportion of serum galactose deficient IgA1 to serum IgA that was making it as a significant predictor for composite outcome in the Cox proportional hazards model. We have done a preliminary panel, Luminex panel of inflammatory biomarkers, and the preliminary results show that there's significantly increased inflammatory biomarkers at baseline. This is a cohort comparison between the UK cohort, the Indian, which is the great IgA nephropathy cohort, and the Chinese cohort, where you can see that the secretory IgA level is much decreased in our population compared to Caucasians or the Chinese. There is the galactose deficient IgA1 level, which is shown in the other diagram, is lesser in our population. But when you look at inflammatory markers, the trend is in the opposite direction, where our population has much more increased inflammatory markers compared to the Caucasian cohort. So this is a retake of the current hypothesis that may be relevant to the South Asian region, which we would say that we will have effect modifiers in our population, could be due to low nephron numbers, could be due to inflammation and occult GI infections, altered gut microbiome, limited access to healthcare, or genetics and epigenetic variation. Thank you.
Thank you, Saxena, for a wonderful presentation. We had 3 presentations, which are from North and South. But the impression one gets is definitely the IgA nephropathy in South Asia is worse as compared with the is coming from Europe or other Western countries. I will give it to understand that we'll have a discussion on these 3 talks. Is okay? So shall we go on? Okay, that's one.
Yeah, definitely one thing has been very clear that we are having a much younger population somewhere in the 3rd and 4th decade of life, presenting either to his general physician or ophthalmologist and occasionally to his nephrologist or maybe cardiologist with sometimes very severe hypertension. This is what we are normally seeing in South Asian population, especially in our country, both from the north side and the southern part of the country. So probably we have to actually start in increasing the awareness among our physicians as well as the other colleagues to actually start identifying these diseases at much early phases, because in our own practice we normally see these patients coming to us with very severe hypertension, sometimes with a systolic blood pressures of more than 200, and often they have only headaches and some blurring of vision and hardly any edematous illness. And probably this is an area where we can actually start searching and probably start identifying these people at a very early stage, because we all know that this is one of the most common glomerulonephritis and often leading to an end-stage renal disease. So my comments.
Professor Sumayajuru, a suggestion is there from audience that we can have all presentation and then all together we can discuss. So we can in the
Okay,
and
I
then we can have.
understand. Definitely just want to echo what Dr. Soumya said. When I joined DM in 1981, we used to call it a benign hematuria syndrome, a Buerger disease. The disease is so much different now. But just now Saxena had told, other people have spoken. It's a totally different, very boxing disease, different ways, and we need to learn more and more. I think we pass on the session to our next chairperson. Thank you so much for giving us a chance to be part of this discussion.
Thank you, Dignitaries, for chairing the session. To chair the second half of this session, may I invite the chairpersons, Dr. Dhananjay Agarwal, Consultant Nephrologist, SMS Jaipur, Dr. Mufazal Ahmad, Consultant Nephrologist and Kidney Transplant Physician, Lucknow, Dr. Debashish Saha, Consultant Nephrologist, Lucknow, Dr. Anil K. Singh, Consultant Nephrologist, Lucknow.
Thank you for getting a second chance to come again and continue this session of IgA nephropathy. While my other co-chairperson joined here, it's my privilege to introduce
I would also like to invite Edwin Fernandez sir and
My
Mohan
co-chair-
Rajput sir.
Co-chairperson are Dr. Rajapurkar, Dr. Edwin, Devashisa. First speaker of this second session, Arpita Rai Chaudhary. You introduce.
Is Arpita Rai Chaudhary here? Yeah, please.
Good morning, sir. I'm here.
Yes, please. She's a professor of nephrology at Kolkata, and I request her to start her presentation on her experience.
So thank you, Professor Narayan and SGPGI team for inviting me here and allowing me to share our IPGMER experience with you. With last three presentations on board, we have certain features associated with it, particularly the last speaker, Susina, has a large contribution from West Bengal too. If you see the geographical map there, among the 201 patients, 76 were from West Bengal. So we expect some degree of overlap, but we do differ in some respects too, so we can share. All of us know this thing that clinical presentation is variable, clinical course is variable, and the spectrums are also variable. Quite rightly, Professor Narayan provided us this template according to which we will set our data so that we can talk similar on one platform. And I will talk to 238 is primary IgN from 2015 onwards, 35 lost to follow up. I will provide the epidemiological data, and I will show you two trials which we showcased in last WCN as abstract, and that has been published as in KIR as abstracts. So before this slide about the prevalence, we have a biopsy registry data published in 2013 in IgN, which quotes IgN nephropathy to be incidence around 8.54%, and more or less across India, we find these 8 to 10% incidence of IgN nephropathy, providing certain very, very advanced cases of CKD presentation, which we have a gut feeling that they might be IgA because of the proteinuria and active sediment in it, a subclinical presentation with such low EGFR, who we have to take in transplant but cannot go for biopsy because of the small size kidneys. Those patients, if taken together, may increase, but most of the Indian studies do quote a prevalence around 8 to 10%. The age group as identified is around 38.7% in 21 to 30, so relatively younger IGAs. There is not much gender preference. Male, female is 1.38 to 1, slightly higher males. Hypertension in IgA nephropathy, yes, I admit there is a stake of accelerated hypertension at presentation when the patients come with severe hypertension and can move on to CKD very fast, very bad course. And sometimes we have seen biopsying those patients have shown us coexistent thrombotic microangiopathy in the biopsy. So I've had seen that there are published documents, also case reports, also IJN with TMA. Primary glomerular disease with a stake of TMA is coming up. We had taken the definition more than equal to 140/90. According to that, hypertension at presentation is 72%, but rest from the rest 28%, almost 22% are on ARB, mostly telmisartan, though not hypertensive by definition, as they get it as antiproteinuric. 6% patients are not getting antihypertensive medications, rather we can't put them on telmisartan 40, even some people are on telmisartan 20. ACE inhibitor is 45%, ARB in 54.7%, dual blockade we don't try much, CCB alpha blocker and beta blocker 51.6%,
and there are at least 5 patients where we needed more than 4 medication. Mean serum creatinine at our presentation, quite contrary to Susina's presentation, is little lower. So it's good that we are now picking up less proteinuric cases. There might have been a vibration created in society among the primary physicians. So we get the referrals early now, and mean eGFR reflected by our population serum creatinine, that is around 80.04, and mean proteinuria at presentation 2.4 gram plus minus 1 gram. So there is a stake of nephrotic plus subnephrotic proteinuria. In one cohort which we have assessed between 2015 to 2018, we found nephrotic in certain excess, and then we found the syndromic presentation went more on favor of subnephrotic proteinuria. Probably again we are picking up earlier probably. The pathological features, there is a striking difference with Susina's finding. Endocap hypercellularity is only 10.1%. Since publication of GRACE 1 cohort, I looked at this high prevalence of E1 43%, because I will show in further trials that how it had showed some relevance in outcome with E1 in Valiga cohort also that was indicated, but repeatedly going back to pathology lab and finding it myself with other pathologists, I didn't find endocap hypercellularity to be that much, and mesangial hypercellularity I find close to 60% in our cohort. So immunofluorescence, there is significant C3 deposition, though I don't feel we have just completed a IRGN study too, where on C3 stake we had given a steroid and that didn't show any positive outcome in non-steroid versus steroid group. So I feel that only C3 deposition cannot guide us up to steroids. The data would show us later on as we will analyze. This is the multi-hit hypothesis. I'm not going in detail. Only thing I want to highlight before going to trials, that whatever data was being poured in the IgA investigation trial repository, it was more, there is a trend of using steroid as anti-inflammatory plus immunosuppression. So we were also tempted to use steroids, either systemic or the budesonide TRF2. I will show that trial within a few minutes. So outcome of patients, that is 238, death over these 7 years, there were 22 deaths, 42 patients had moved on to dialysis, eGFR less than 30 is 34, and lost to follow-up was 35 patients. Nearly 100% patients, we are able to use ACE inhibitor ARB, and it is, we have seen that these patients tolerated ACE inhibitor ARB use rather than other group of glomerular disease patients. They have tolerated quite well. We do not use fish oil. We have used antiplatelet agents in 12% patients, statins in up to 30%. SGLT2I is very less. It is around 20 patients, I think, and in a 200 patients cohort, it will come to 10 to 12%. We haven't, we have gotten in between 2 patients who have developed AKI on SGLT2I, and 1 patient biopsy showed AIN. Immunosuppression use as provided by template by Dr. Narayan. Corticosteroids were main around 60%. We do never use corticosteroids beyond 20 mil eGFR. Now, after the steroid, systemic steroid trial, our institute protocol again goes back to less than 30. We will not be using corticosteroids if the IFTA is significantly high. Azathioprine nil, CNI nil, we don't use rituximab as well, and mTOR inhibitors also we do not use. Immunosuppression use is corticosteroid, cyclophosphamide, UVAS protocol. We use if the fibrotic component is not too high, we use corticosteroid and cyclophosphamide. Also the patient's clinical picture also decides for how aggressive we will go with immunosuppression. So about treatment documented by testing and stop IgN trial, there were striking differences in response to corticosteroid immunosuppression in different IgN population. What Susina was pointing out, definitely our gut feeling is there. We have some separate genetic risks. We have some separate modifiers in terms of infection, which may be the altered gut microbiome too. Propensity for more severe inflammatory disease in different ethnic population. So there is a relevance of putting our own data on table and think over how we can give best benefit with minimal side effects with treatment. The IgN single center observational study, which had been this year showcased, is we had tried with, this was the earlier trial. It was completed in 2016, part of a thesis of a student, and the patients were followed up again for 2 years after that. And now the data is ready to share. Proteinuria more than 1 gram per day, despite 3 months of optimized supportive care, received 6-month course of corticosteroid therapy, oral prednisolone starting from 1 milligram per kg per day for 2 months and then reduced to by 0.2 milligram per kg per day, rounded off to nearest 5 milligram every 2 weeks to reach a minimum dose of 5 milligram per day. And the outcomes that we have kept in that trial was change in eGFR and proteinuria in 6 months and 12 months from baseline and association of MEST scoring with response to steroids. There were small number of patients, only around 30 patients who received both steroids and ACE inhibitor ARB. 15 patients were only ACE inhibitor ARB and mostly in the range of proteinuria of 1 to 3 gram. And exclusion was no concomitant renal disease and no presenting vasculitis, no secondary IgN. So you can see that by 12 months there was a moderate fall in proteinuria, but that was not translated in eGFR improvement that much. It was stable in the steroid receiving group eGFR. The creatinine didn't improve much and the proteinuria only came, and steroid therapy for 6 months resulted in significant reduction of proteinuria at 6 and 12 months, but eGFR didn't change significantly over 1 year. Presence of endocap proliferation was associated with significant proteinuria reduction on steroid therapy. On longer follow-up for 3 years, patients with less than 30 ml per minute eGFR and IFTA more than 50% had GFR loss more than 5 ml per minute. Infection-related admissions were numerically more in steroid arm, weight gain, cosmetic changes, new onset diabetes, all these side effects were frequent. We were close to the summary and conclusion by stop IgN trial that immunosuppression did not affect the GFR loss at 3 years. So after that, we had shown an open label, we are going to show now an open label RCT in proteinuric Indian IgA nephropathy patients. As there was steroid related adverse effects stay, we were thinking of TRF budesonide, whether can improve the outcome. The trial description is open label RCT, 6-month run-in, 9-month treatment and 6-month follow-up phases were conducted in nephrology department. What in extra than the Nefigan trial we did, that we had a post budesonide withdrawal follow-up too for another 6 months. So at 15 months, we again looked at the cohort who received budesonide, what was happening to them. Total of 71 patients, more than 18 years of age, persistent proteinuria more than 1 gram per day, receiving no immunosuppression in last 6 months, were screened, of which 65 patients were enrolled for run-in phase. 53 patients could be randomized in 1:1 fashion to receive either the conservative therapy alone or 18 milligram self-administered oral TRF budesonide with the conservative therapy 27, intervention arm 27 patients and 26 in conservative arm. This is the trial flow chart which I have already told. Primary outcome were to measure the changes in 24-hour urinary protein excretion and change in estimated GFR at the end of treatment. safety was assessed in all patients. This is the baseline. I'm not going in detail, but you can see in all respects they are similar. We do not have any difference. So these showed that significant eGFR improvement happened in 9 months after 9 months of budesonide therapy, and this is showing the improvement of proteinuria in the intervention arm control compared to the control arm 2. Both have come significant. How long we are to give budesonide? Should we stop at 6 months? Because side effect profile was very, very acceptable. Only one LRTI, and the face was slightly puffy. Now, I won't say that it had no cosmetic side effects of steroid therapy, but face was slightly puffy at the end of 9 months. By looking into outcome post 6 months of withdrawal of TRF, out of 27 patients who received budesonide, 4 had uncontrolled blood pressure. So we excluded them for analysis. Out of rest 23 patients, 12 had increased proteinuria after withdrawal of TRF budesonide. Patients with rising proteinuria have started documenting marginal rise in creatinine too. So this was the figure that we had achieved. For patients with increased proteinuria were 12, without increased proteinuria 4, and patients with stable GFR were more in the no proteinuria group. So we looked at that what can be which variable can be the best one. The sample size is very small, so again we may be misguided too, but this time again the M1, E1 lesions came as to be related to increased proteinuria. 2 trials done in different time frame and different group of patients, they are showing this. So we think that these inflammatory lesions, E1 is associated with more inflammatory cell recruitment in the glomerulus. They might have some stake on decision of treatment. We are searching evidently, as Shamita had shown, Susina had shown, the basics research people are trying more and more to relate the biomarkers so that we can find out the exact group where we should try immunosuppression, where we should go with minimal immunosuppression, more conservative, and for that E1 may come up as a significant histological finder, which will be available with most of us. That is the issue. The other biological markers may not be available with all budesonide and the clinical practice platform of the country. So TRF budesonide has the potential to become a first disease-specific treatment for IgA nephropathy with an acceptable risk-benefit profile. Duration of therapy to provide sustained benefit is yet to be determined. Presence of mesangial and endocapillary proliferation may need longer therapy. And with that, I hope, as Dr. Bharat has shown, multiple things are being worked up. We are going to see a better future. Thank you all.
Thank you, Arpita. Now, my privilege to invite Padam Shri and VC Raya body, Dr. A.K. Balla. He is chairman of nephrology in Sir Gangaram Hospital and Research Center. He is also the president of Institute of Nephrology. You already heard him talking about the anti-APRIL antibody trial that he is undertaking, and I'm sure we'll be fruitful discussion after all these presentations. Over to you, Dr. Balla.
Thank you, sir, for the kind introduction. At the outset, I would like to thank Professor Narayan Prasad for giving me the opportunity to share this data from our center. I am going to present the data in the format which he had given to us for a uniform presentation for all the centers. And I must congratulate Professor Narayan Prasad that this is the first kind of multi-center study going to be, and I'm sure that that should be the direction forward from Indian Society of Nephrology point of view also. And we should aim for other diseases like membranous nephropathy, then transplantation, AKI, ABO incompatible transplantation. So I'm sure this is going to be, if we involve at least 10 or 20 centers from the country, and we then after that we can have our own guidelines also as far as therapy is concerned. So coming to our SGRH data, The mean, we had analyzed 209 patients out of 2,400 biopsies done from 2013 to 2018. And this comes to about 8.7% of IgA nephropathy at the biopsy. Ours is a private setup and a tertiary care hospital. So, but still, more or less, it is comparable with the other presentations which we have seen so far. Actually, we didn't include the last 2 years data because of the COVID. The biopsies number were less. So I have not included that yet. And on an average, we are doing about 400 biopsies in a year. The mean age was 34.86 and there was a male preponderance. The hypertension at presentation was seen in 25.35% of patients, and antihypertensive medications on an average mean was 2.1, and creatinine at presentation. Somehow we had actually higher presentation creatinine and low GFR at the time of presentation. That is 3.1 was our mean creatinine presentation. So that is actually higher as compared to some of the other centers experience. eGFR at the presentation again mean was 23.3. So that means that patients are coming to us at a much lower GFR and much later rather than in the previous presentation from Calcutta, which had quite a significant population with asymptomatic urinary abnormalities and GFR as high as 80 ml per minute. Proteinuria was seen in the 3.18 and nephrotic range proteinuria was seen in almost 1/3 of, but that is a very significant, that majority of the 1/3 of patients were having nephrotic range proteinuria, and microscopic hematuria was seen in 76.15%. That is quite expected. Now coming to syndromic presentation, the nephrotic syndrome was actually seen in 30.14, macroscopic hematuria 10.7%, where patients presented with gross hematuria, and CKD at presentation 17.2%, AKD in 33.3%. This included actually patients of RPGN also, and asymptomatic urinary abnormality seen in 8.63%. Coming to pathological features, diffuse global sclerosis, more than 50% was seen in 5.7% of patients. Mesangial hypercellularity, M1 according to MEST score, 88%, and endocapillary hypercellularity was not seen actually in majority of patients. It was in 16% of patients. And FS, this segmental sclerosis was seen in 55% of patients because patients' presentation actually was with lower GFR. Moderate to severe tubular atrophy, more than 25% of sampled cortical area was seen in 33% of patients. We didn't have much patients who had recent, and more than 25% recent were seen only in 1% of patients. And immunofluorescence studies, IgA deposition 3+ or more was seen in majority of patients, 2/3 of patients, and IgM in addition was seen in 38 and C3 deposition in 22%. Now coming to treatment of IgA nephropathy, ACE inhibitors or ARBs were used in 76.6% of patients. Fish oil, the omega-3 fatty acids were used in 6% of patients. Antiplatelet agents were used in 7.7% of patients. Statins, as per indication, was used in 40%. Hydroxychloroquine was used in 3.8%. And SGLT2 inhibitors, which we have started using only since last about 1 year, and that was used in 26.8% of patients. None of the patient was put on dual RAS blockade. Now, as far as immunosuppressive treatment is concerned, steroids were used in 44.9% of patients. MMF was used. Initially, we used MMF, but now we have stopped using it, and 7.6%. Cyclophosphamide in 9.6%, azathioprine in 4.3%, calcineurin inhibitors in 6.7%, rituximab only 1.9%, and mTOR inhibitor we didn't use in any of the patients. As far as immunosuppression used for recent IgA nephropathy C2 regions or more percentage. Corticosteroids plus MMF in 6.2%, corticosteroids plus cyclophosphamide in 9.6%, corticosteroids plus azathioprine in 0.9%, rituximab in 1.9%, no immunosuppression 1.9%. Now, we just analyze the follow-up, and it was mean duration 43 plus 12.7 months. 4 patients died on follow-up, 24 had ESRD, and 18% are on hemodialysis, 1 on PD, and 5 patients underwent kidney transplantation. So that is the center from data from Dandaram Hospital. And now we can have that discussion. There is almost 30 minutes kept for discussion. I'm sure we will have some consensus after that. Thank you.
Thank you, sir. We now go on to the presentation from Sanjay Gandhi Institute, Dr. Mudit Khurana. He will present the data from Sanjay Gandhi Institute.
Good afternoon, everyone. At the outset, I would like to thank Narayan Prasad sir for giving me this opportunity to present my research work which I had done during the time of my residency at SGPGIMS. So I'll be sharing the experience from our institute about IgA nephropathy. Before starting, if we talk about IgA nephropathy, the first thing that comes to our mind is the geographical variation in the disease. So if you look at the prevalence, biopsy prevalence, it ranges somewhere between 10 to 20% in United States. It is slightly higher in European countries, somewhere between 20 to 30%. In Asian countries like Japan and China, where screening is very robust, this incidence is highest, somewhere between 40 to 50%. In India, various studies have shown the biopsy prevalence to range from 5 to 15%. And this variation is not only in the prevalence, but it is also in the clinical and pathological presentation. And it is not only within the between the countries, but this variation is seen even within the countries. And if we look for the reasons for this variation, so first important reason would be the genetic background. There have been candidate genes as well as risk-associated and protective alleles that have been identified for IgA nephropathy. But there are two important biases which come into this variation. First is the access to primary care. So in developing countries, what is happening is that patients with asymptomatic urinary abnormalities, they very rarely reach a specialist for biopsy. And by the time they reach a nephrologist, probably biopsy is not possible. And then there are differences in policies for performing renal biopsies at various centers. So firstly, I'll talk about primary IgA nephropathy. We analyzed data from 2007 to 2018. We could find 560 cases of primary IgA nephropathy. And the demographic profile was similar to the previous speakers, what they told about their centers. The mean age was around 32 years and the male to female ratio was 2.5:1. And if you look at the age distribution of the cohort, the most of the patients are between 21 to 30 years of age. A clinical presentation at our center, what we found was hypertension was seen in around 70% of the patients, and the average number of antihypertensive medications required was 2.1. Median serum creatinine was 2.3 milligram per deciliter, and the median eGFR was 34 ml per minute. And if you look at the GFR distribution, we'll see that nearly 70% of our patients had a GFR below 60 ml per minute at the time of presentation. And coming to proteinuria, the median proteinuria in our patients at the time of presentation was 3.24 grams per day, and microscopic hematuria was seen in around 63.2% patients. One finding was that we found that 46.8% of our cohort actually had nephrotic range proteinuria, where proteinuria was quantified to be more than 3 grams per day. And macroscopic hematuria, which is the classical presentation of IgA nephropathy, was only seen in 5%, 4.6% of our cohort. So the clinical phenotype which we are seeing is probably mostly a young male, 20 to 30 years of age, and 2/3 of them present with hypertension and renal failure at the time of presentation. Almost half of these patients have proteinuria more than 3 grams per day, and microscopic hematuria is very common, but macroscopic hematuria is a rare finding. Pathology, one striking finding was that nearly 1/3, 31.6% of our patients had diffuse global glomerular sclerosis, that is more than 50% of the glomeruli showing global sclerosis. This was at the time of presentation. So we could apply Oxford MES-T classification to only 339 biopsies. 221 biopsies were excluded as they contained less than 8 viable glomeruli or they had DGGS. When we analyzed the MES-C scoring, we found that mesangial proliferation was seen in around 67% of the biopsies, significant enough to be classified as M1. And endocapillary proliferation was not that common, seen in 23.9% of the biopsies. Segmental sclerosis in 46.9%. And one thing was there that even these biopsies, out of the, after excluding patients with DGGS, nearly 1/3 had significant tubular atrophy with either T1 lesion in 28.3 or T2 in 4.7%. And crescents probably in our cohort, they are more common than the previous centers, and it was somewhere around 20%. So pathological phenotype, 1/3 of our biopsies, IgA nephropathy biopsies at the time of presentation had diffuse global glomerular sclerosis. Out of the remaining biopsies, 1/3 had significant tubular atrophy, in which the tubular atrophy was more than 25%, and crescents were seen in nearly 20% of the biopsies. So we also looked into the management which was done, because it is physician specific and unit specific. So what we found was that AC inhibitors or ARBs were used in 54.4% patients. There was no patient who had received dual blockade. TCBs were used in around 33.6% patients. Fish oil use was negligible, and nearly 44% of our patients were given some form of immunosuppression. And the most common regimen was when oral steroids were used alone. They were combined with MMF in 12.5% of the patients, and steroid plus cyclophosphamide, either oral or IV, was used in around 4.4% patients, and mostly this was used in patients who had C2 lesions or more. So primary IgA nephropathy, it tends to, what our cohort says is that there is greater proteinuria, a higher incidence of kidney failure and hypertension at the time of presentation, and most of our population presents with established CKD and morphologically a burnt out disease with advanced glomerular sclerosis and tubular atrophy. We also analyzed the subset of patients who had C2 lesions or more. So in this subset of precentric IgA, we found that the demographic profile was similar, with age, mean age being 30 and male preponderance, but there was slightly, the mean creatinine had to be higher. It was higher than the overall cohort of around 4.7 milligram per deciliter. Proteinuria was higher. The mean proteinuria at the time of presentation was around 4.2 grams, and 40% of these patients who presented to us required dialysis at the time of presentation. So we analyzed the pathology of these patients who had precentric IgA, and what we found was that out of the total glomeruli which were there in the biopsies, 20% showed cellular crescent, 38% shows fibrocellular or fibrous crescent, and 25% had global glomerular sclerosis. So, and even in these patients who had precentric IgA, they had tubular atrophy more than 25% in 65% of the samples. So probably this precentric IgA is different from say post-immune crescentic glomerulonephritis, and this occurs on the background of chronic IgA changes. Management protocols for crescentic IgA, nearly 50% of the patients had received steroid plus cyclophosphamide. Steroid alone was used in 32% of the population and steroid plus MMF in 8.5%. Nearly 3% patients had also received plasma exchange therapy for this crescentic IgA. So, when we analyze the outcomes of patients with crescentic IgA, we found that at the end of 1 year, partial or complete remission was achieved in only 34.6% of the patients, and the remaining had either reached ESRD and around 2% had died. So, when we analyzed further, we found that the estimated renal survival at 1 year was around 37%. And when we compared it with post-immune crescentic glomerulonephritis, we found that it was significantly lower. 1 year renal survival for post-immune crescentic glomerulonephritis was somewhere around 77.7%. So, at crescentic IgA, what our center cohort shows is that crescentic IgA have increased chronicity in renal biopsies, which suggests that this transformation, crescentic transformation, probably occurs on the background of chronic IgA nephropathy. Diffuse crescentic IgA has a poor prognosis even when given aggressive immunosuppression, and the higher chronicity may be the reason for this poor renal survival. Lastly, I would like to share our experience about post-transplant IgA nephropathy, that too in living donor transplant. So this is one of our papers about the outcomes, long-term outcomes of post-transplant IgA nephropathy. So we could find 51 patients who had post-transplant IgA nephropathy, and out of that, 40 patients had a biopsy-proven pre-transplant IgA nephropathy. These 40 were proven recurrence. So the mean duration for clinical recurrence of IgA nephropathy after transplant was 5.2 years. The mean proteinuria at the presentation was 3 grams per day, with nephrotic range proteinuria being seen in 41.2% of the patients. Microhematuria was less common than seen in primary IgA nephropathy, and the serum creatinine was, mean serum creatinine at the time of presentation was 1.1 milligram per deciliter. So, considering that post-transplant patients are followed up vigilantly, we are detecting post-transplant IgA nephropathy earlier, and similar findings are reciprocated in the pathology. We found that DGGS was seen in only 9.8% of the cohort and significant tubular atrophy in only 17.6% of the patients. But when we did the survival analysis, we found that estimated mean graft survival of these patients who had post-transplant IgA nephropathy was significantly lower than most of the registry data. Estimated mean graft survival at 5 and 10 years was 88.5% and 44.6%, and death-censored graft survival at 5 and 10 years was 86% and 65% respectively. So, post-transplant IgA nephropathy, we are detecting it earlier, but overall, in these patients who have a recurrence of IgA nephropathy, the long-term graft survival is actually lower than the overall graft survival reported from most of the registry data. Thank you.
Dr. Neha from Sawai Madhu Medical College, Jaipur, to talk about her center data about IgA nephropathy.
Good afternoon. Myself, Dr. Neha Sharma from SMS Jaipur. I'll be presenting my study on clinical profile and histopathological spectrum of IgA nephropathy in a tertiary care hospital of Northwest India. So, introduction, IgA nephropathy is the most frequent primary glomerulonephritis worldwide. It is characterized by predominant mesangial IgA deposits on kidney biopsy. Prevalence of IgA nephropathy varies across the world, with the highest values in East Asia, reaching 40% of biopsies in Japan, 25% in Europe, 12% in United States, and below 5% in Africa. In the map, it shows geographical variation in genetic risk for IgA nephropathy. Green area shows low risk and red area shows high risk area. In India, the initial study was by Wuhan et al. In 1992, which reported a prevalence of 7.24%. In northern India, it reported a prevalence of 10.4%. In one study from Western India, it reported 14% prevalence of IgA nephropathy. So aims of my study is to study the spectrum of clinical presentation and histopathological findings of IgA nephropathy at our institution and to study the outcome. Methods. Inclusion criteria. All patients diagnosed to have primary IgA nephropathy on native kidney biopsy in our nephrology department from January 2020 to December 2021. Exclusion criteria include secondary causes of IgA nephropathy, patients with a second coexisting disease on kidney biopsy like diabetic nephropathy, inadequate missing clinical records and inadequate kidney biopsy. All kidney biopsies in the study report based on IF criteria of dominant, codominant IgA staining of intensity more than 1+ on a scale of 0 to 3+ were retrospectively reviewed. In all biopsies with more than 8 viable glomerular, the meshed C scores were analyzed according to the Oxford criteria. Clinical characteristics and baseline demographic data were collected, including age, gender, systolic blood pressure, and diastolic blood pressure. The data was collected for presenting complaints, clinical diagnosis, urine analysis, create, albumin, 24-hour urine protein, uric acid, lipid profile, and biopsy findings on light microscopy and immunofluorescence, and subsequently urine analysis and serum creatinine were determined at follow-up. Patients were treated with optimal blood pressure control with ACE inhibitors, ARBs, and immunosuppression as per indication according to KDIGO guidelines. Results and analysis. Out of total 430 native kidney biopsies in our institution done during the study period, 61 renal biopsies, that is 14.2%, were diagnosed as primary IgA nephropathy and met our study inclusion criteria. Various other studies from India show a prevalence of IgA nephropathy varying from 7 to 16%. In our study, more than 3/4 of the patients, that is 77%, were male, while remaining 23% were females, with male to female ratio was 3.3:1. Mean age was 30.5 years plus minus 12.22 years, with minimum 16 years and maximum 61 years. Majority of the patients, that is 31.1%, were 21 to 30 years old, followed by 11 to 20 years old, which contributed 27.9%, and then 31 to 40 years old. By applying chi-square test, the relationship of age and gender was found to be statistically non-significant. So it was found that most of the patients presented in second and third decade. Distribution of clinical syndrome. Most of the patients were presented as CKD, that is 45.9%. 29.5% presented as rapidly progressive renal failure. 14.8% presented as nephrotic syndrome. 8.2% as acute nephritic syndrome, and 1 patient presented as macroscopic hematuria. So below is the table showing baseline clinical and laboratory profile of patients at the time of biopsy. Mean systolic blood pressure was around 155, mean diastolic blood pressure was around 93, mean serum uric acid was around 5.8, and mean serum albumin was around 3.21 gram per deciliter. Among all patients, majority of the patients, that is 65.6%, had edema. 49 patients, that is 80%, were newly detected hypertensive or were on hypertensive drug before this presentation. 12 patients, that is 19%, presented as hypertensive crisis. So although hypertension is variable across the studies ranging from as low as 66% to as high as 65% in Valiga cohort, in most Indian studies it is present in more than 35% of cases, approaching 78.8% in one study, and in our study it was 80%. Mean proteinuria was around 2.46 plus minus 1.9 gram per day, out of which 24 patients, that is 39.4%, had nephrotic range proteinuria, and 37 patients, that is 60.6%, had subnephrotic range proteinuria. So subnephrotic range proteinuria is a more common presentation in our study, as compared to nephrotic range proteinuria. In many Indian studies, nephrotic range proteinuria with edema was the predominant presenting feature, with the prevalence of nephrotic range being a minimum of 23% and maximum of 63.1%. In our study, 52 patients, that is 85.2% of the patient had hematuria, or out of which 5 had gross hematuria. Mean serum creatinine was 5.6 plus minus 4 milligram per deciliter, and mean eGFR was 28.4 plus minus 33.6 ml per minute per 1.73 meters square. 10 patients presented with eGFR more than 60, and 46 patients had presented with eGFR less than 30, and 20 patients were hemodialyzed at presentation. So, distribution of pathologic features in kidney biopsy based on Oxford classification. In our study, mesangial hypercellularity was found in 39.3% of the patients. Segmental sclerosis was found in 96.7%. Endocapillary hypercellularity was found in 27.9%. Tubular atrophy interstitial fibrosis, that is both T1 and T2, were found in around 75% of the patients, and C2 patients were found in 6.6% of the patients. So in our study, segmental glomerulosclerosis was present in majority of the patients, that is 96.7% of the patients, which varied from other studies. The MEST criteria was correlated in nephrotic range and subnephrotic range proteinuric patients, and it was found out that there was no significant difference in MEST characteristic of patients presenting with nephrotic range compared to those with subnephrotic range proteinuria. MEST-C was correlated with eGFR at presentation, and it was found out that association of tubular atrophy and interstitial fibrosis with decreased eGFR at the time of biopsy was found to be statistically significant. Another salient feature of our study was high prevalence of thrombotic microangiopathy in kidney biopsy. 23 patients, that is 37.7%, had TMA on kidney biopsy findings. Among 49 patients of hypertension, 20 patients had biopsy finding of TMA, and among 12 patients of hypertensive crisis, 10 patients had biopsy finding of TMA. So TMA in IgA nephropathy usually results from accelerated hypertension. So out of 61 patients, 9 patients were lost to follow-up. Remaining 52 patients were followed up for at least 6 months with maximum of 18 months with a median follow-up of 10.2 months. Of the 52 patients with follow-up, 27 patients, that is 44.3, received ACE inhibitors ARBs. 34 patients were given steroids, that is 55.7%, while 10 patients, that is 16.4%, received other immunosuppressive therapy. 15 patients were dialysis dependent after the initial presentation or at the time of diagnosis, and out of the 37 patients left, 10 patients, that is 27%, had remission, out of which 6 patients had presented with nephrotic, 2 patients with RPRF, and 2 with acute glomerulonephritis, which responded to non-immunosuppressive antiproteinic treatment and immunosuppressive. 14 patients, that is 37.8%, showed no response or gradual progression and remained in CKD stage 3 to 5 with mean eGFR of 27.6, and 13 patients had progressed to end-stage renal disease. So out of 28 patients in end-stage renal disease, 7 patients had expired and 8 patients had underwent renal transplant surgery. Limitations of the study was there was a significant reduction of total number of renal biopsies in our study due to impact of COVID-19 pandemic in that period. Shorter duration of follow-up was the main limiting factor in this study. Most of the patients diagnosed with disease at an advanced stage of presentation. Therefore, correlation between eGFR and clinical and histopathological parameters were not apparent at follow-up. Conclusion: in our study, most cases of IgA nephropathy were seen in second and third decade with male predominance. CKD and RPRF were common clinical presentation of the disease. Most of the patients presented with renal dysfunction with need for hemodialysis. Hypertension was present in majority of the patients. Patients with nephrotic syndrome were more likely to achieve remission, and about 1/3 of our follow-up patients reached PSRD, which stresses the fact that IgA nephropathy in our population is a very aggressive disease. So many of the young hypertensive patients are because of IgA nephropathy. So we can have low threshold for kidney biopsy if urinary and/or renal function abnormalities were detected at that time. Many patients of IgA nephropathy have malignant presentation of the disease. And as asymptomatic urinary abnormality is the most common presentation worldwide, so routine urine screening may be needed for detection of IgA nephropathy at an early stage. Thank you.
Thank you, Dr. Neha. I think we had a very fruitful discussion on IgA nephropathy after the initial talk by Jonathan Barrett. We had 7 talks from different parts of the country. The overall impression one gets is what we see in India as compared with what we see in Europe and other places is we see more severe presentation in younger age with hypertension and with renal failure, more chance of presenting TN. And of course, different trials have been going on. Before others maybe start, I think all speakers are available here in the hall. Dr. Arpita, may I start with you? Glutinous tonight, you said a lot of discussion on that. I'm sure you are getting it part of trial. Is this available to other people also, but in some form?
Sir, ideal Nefigan study talked of that budesonide, which is not available in India. What was available for gastroenterology people's use purpose, we have used the same budesonide that is available in the market. People can get that.
Okay.
This is just a general comment that most of the IGAs that we see come in very late. So they come in with severe hypertension, severe renal failure, almost CKD5. So at that point, we are unable to try any other therapies other than to control hypertension and probably prepare them for transplant after ensuring that there is no AKI. As we know, about 5 to 10% of patients can have an AKI. So, and the other thing is all of us are speaking about ideal blood pressure control. So what is the ideal blood pressure control that we are looking at?
Yeah, the blood pressure, I have mentioned that we usually target less than 130/80. It was a population whom I covered from 2015 onwards. It was a standard set based on the KDIGO guideline that if proteinuria is more, we probably will try even lesser. And the sprint encouraged me to do that more again. So for younger patients, I am trying to go below 120/70, 110/70 if they can tolerate and do their job there. That's why I mentioned that around 22% patients who are not hypertensive at presentation by the data by the thing that I diagnose hypertension, but still they are on. And regarding these late presentation, I think one message must percolate into the primary physicians that whatever be the age of hypertension presentation, never restrict yourself from evaluating the urine, which is very low cost, but very, very informative. And number 2 is getting a creatinine urea done to evaluate the renal function. Many of our young viewer hypertension cohort also go and manifest and come to us with advanced renal dysfunction in second decade. And third thing is, I had done a study I published in KIR on asymptomatic urine abnormality documentation in a school children group, and that was more than a 10,000 cohort. I couldn't do any longitudinal trial. I didn't have any funding anymore, but that was a cross-sectional trial, but that showed that significant number of young students from 8 to 18 years of age, they had proteinuria. And they are also getting some important CKD risk factors that may come up as epigenetic factors. Obesity is being high in childhood, and that is documented that BMI was very high in that both 8 to 12 year, I divided into 2, 8 to 12 and 12 to 18 year. 12 to 18 year had started having proteinuria and hematuria. A longitudinal documentation would be more relevant if we can show that this proteinuria and hematuria is persistent, and tapering down to number, we can subject them to renal biopsy and can look at that whether they are really IgA patients. These screening studies had helped many Malaysia, China, Japan to pick up the disease early, many IgA early, and gradually their CKD, IgA as cause of CKD has come down. So we have to think about, may go to Ministry of health and family welfare, once we accumulate all these data, that we are finding this disease at this severity. So we may think of a universal mandate for school health, include urine abnormalities as a part of school health screening.
Yes, you're right. Japan has a very active school screening program, and that's the reason why they pick up a lot of IGAs. I completely agree. Agree with you.
I found Japan has a state of 61%,
Right.
which is not evident even in Chinese population. The Chinese population also reported the E1 stake to be in our range only, but the Japan has documented
Yes,
in
definitely. That's because of your program. Dr. Narayan?
So that we all understand that screening in Japan in the school is a very well-known fact. They have higher incidence of the IgA nephropathy. What we have seen, the purpose of getting this all-centered study, we have in last 6-7 years, we have seen particularly Christina and Samita, Arpita, they are all doing good work on IgA nephropathy. So, and when we are analyzing our data, that was very diverse. And our patients are approximately more than 37% of the DGS coming, and we are doing the biopsy. Whether this percentage was mainly because of the late coming of the patients to us and the more aggressive in doing biopsy. What we have seen, serum creatinine, Dr. Arpita's surprisingly was very low, 1.1 milligram, and hypertension in that proportion was very high. Whether we have seen in the data of Gangaram, the serum creatinine was a little bit higher, 3.1 at presentation, and but the hypertension was looking relatively less. So that kind of the variation is there. So really, it is possible that there might be some problem in getting this retrospective data. But what was important that in every data, what we have seen, the age of the presentation is similar. Most of the patients had a higher serum creatinine level. Most of the patients had hypertension. Histological criteria was a little bit varying. Dr. Sushila, any of your comment about this, because you have the only prospective cohort of that you have presented.
Thanks, Dr. Narayan, for that question. So one thing before I say is, look, we cannot compare histology between studies, especially when it's being done by different teams. So when histology has to be compared by different centers, it needs to be done by a single team or by two members sitting together and reviewing all biopsies. So there's significant variations between pathologists. The other thing is, I didn't tell it, but we had shown a slide which showed that glomerular sclerosis, the median glomerular sclerosis was 33% in our cohort, and about, if I remember correctly, about 30% had more than 30% glomerular sclerosis was present in a significant amount in our cohort. So that is correlating with your.
Sushina, please speak in the mic. We are not able.
And we did have higher sclerotic and T1 and T2 lesions, but we also saw that these lesions were there even in a relatively well-preserved EGFR and low proteinuria, which showed that even at an earlier disease stage, which was clinically looking earlier, there was a histologically chronic lesions.
Do I understand? But what you saw, Sushina, maybe patients with you said GFR was little preserved and more proteinuria. Is there some different profile of patients from north versus south? Maybe, of course, point is well taken that we should have a combined study that Bal already mentioned with common registry and things that will take time. But it could be the difference between south versus north. Is it region-wise? Because India is a big country.
I'm not sure whether there's a real difference between that, because even our cohort, we had a significant representation from central, north central and northeast as well as the south parts of India. And we didn't find
and your data included many people from Bengal also.
Yeah, and we didn't find any difference between these groups. So.
I have two questions. One is, the majority of the patients on IgA nephropathy with the proteinuria getting the mainstay of the treatment is ACE or ARB. Now, what is the primary indications to start the steroids? Is it a acute tubular inflammation, or it's a nephrotic granuloproteinuria?
So right now,
my second question is, with the use of the ACE inhibitor, there will be a rise in the creatinine level. At what level you will stop the use of ACE, and what antihypertensive would be of much when you will be choice to add on to decrease the proteinuria to retard the progression?
So I can say only about our center experience. I'm sure other centers have different protocols. Our center, basically, if there is proteinuria, significant proteinuria, even on stable RAS, as well as if there is low EGFR, more than 20-25 of course, we will start them on a short course of steroids, which is 2 milligram per kg per alternate day over 3 months, and then taper and stop it over 6 months. This is because, unfortunately, these patients don't have access to any other kind of treatment which will halt their disease. And as we saw even in the longitudinal cohort, that the progression, the rapid progression and the composite outcome is very high when we follow up these patients. So unfortunately, even though the risk of infection is more, we have our toxicity data in the paper. I haven't put it up here. We definitely do have increased risk of infection. But at this situation, we do not have any other immunosuppressive drugs to give them. Probably with targeted therapy, that will be the way forward. So that's
Dr. Anil, want to say?
Thank you, Sushila. Can I comment on the same thing from Samita?
2018, we have the prospective cohort for supportive treatment. So for now, as a protocol, we wait for 6 months. If the patient's proteinuria is not increasing significantly and the EGFR is stable, we don't go on to immunosuppression. And we would never start immunosuppression below a GFR of 30. We've had very bad experience with infection, and it does not affect the outcome, at least in our cohort. So we don't start any immunosuppression below 30. We give supportive therapy for 6 months. And then if the proteinuria is persistently more than 1 gram, then we go on to steroids.
Dr. Samita, I asked a question to the speaker, Dr. Jonathan Baird. Same question I asked you. A patient of 30 years, creatinine of 2, IFTA is 25%, and proteinuria is around 4 grams.
So we would still start on ACE inhibitors, but I will watch very closely, maybe monthly follow-ups. And if the proteinuria does not come down below 1 gram, or if
at this point of waiting, the response to ACE inhibitor to me seems somehow not acceptable. How long to wait?
So, but the steroid also has issues. It has issues. It is not as safe as we think it is. And if you start steroids in a patient with a compromised GFR, they actually start progressing in some cases. So you need to be very careful when you start. So honestly speaking, when I started out in nephrology, I would be using a lot of immunosuppression and IgA. And from that, I've had a drastic change, because the first, I didn't show it here, but the first data on steroids I had presented a few years back in USN. The response is good initially, 50% do respond, but the infection rate is very high. And the second thing is, what happens when it is not like the patient goes into remission and then the proteinuria stays low. Again, the proteinuria will start increasing when you taper off steroids. What do you do then? Do you keep on giving steroids? You cannot do that because of steroid toxicity. Then you add MMF. So
I do agree. We have a low threshold, like the example of membranous nephropathy. We have been using so much of steroid. Now the studies wait for, if less than 4 grams, wait for 6 months. That's again something. Others, Dr. Anil, you want to say?
Okay, one of the chairperson asked about. In fact, we continue ACE or ARBs to the maximum tolerated dose, and we just monitor hyperkalemia. And I don't think we stop ACE inhibitor or ARBs that week. That is continued. The initial GFR for about 20%, that is acceptable. But after that, I think long-term use is definitely beneficial. That is the only treatment actually, non-immunosuppressive treatment. As far as steroid is concerned, if the GFR is less than 30, then we don't consider steroids at all. I think GFR is a very important for deciding steroids. But if GSR is more than 30, suppose around 60, and nephrotic range proteinuria, we will definitely give one course of steroids and see the response.
Another question I have in mind, just a doubt. The way we see the KC, the severe presentations, where is the role for a lot of therapies which Dr. Jonathan discussed, and you also we were doing anti-peak, anti-April, and then a lot of other agents are being used. Will the day come in short enough 5 or 10 years? Will we be able to use those drugs, the sort of patients that we see here?
Sir, actually, in our practice, what we see, those patients, glomerular disease does not matter too much. Those who have interstitial fibrosis and cellular atrophy of more than 40-50%, these patients are likely to develop steroid-related toxicity and more likely to not to respond kind of patients. So rather than looking at some of the glomerular sclerosis, sometimes we might have the 2-3 global glomerular sclerosis also, might have some partial sclerosis, but problem there always, I agree with Samita. Whenever you go aggressive treatment with the steroids, most of the patients land up with the pneumonia after 2-3 months. So moderately, when we see the endocapillary proliferation is there, some inflammatory changes are there, then you can try steroid. We do steroid. We have seen we are giving steroid plus MMF. One randomized controlled trial of the steroid plus MMF came last week probably in kidney blood pressure research. I have not gone through that. What was the result of that? But that has been published. So I have not looked at that. In our practice, what we do, we give steroid only when the patient do not have too much of the interstitial fibrosis and cellular atrophy. If it is there, then likely there is any chance of this one. As far as the concern of the M1 or E1, histopathologist reports this. So next classification is easy. I do not agree with the Susina on this point. If it is there or not there. So M0, M1, E0, E1. So any of the good histopathologists, if they are reporting, only problem is there the T0, T1, T2 and fibrosis similarly. So there a little bit difference might come. But endocapillary proliferation, mesangial proliferation or expansion is there or not, that is very easy to determine in the next classification.
One provocative comment. This Oxford classification, best classification actually does not guide your therapy.
Gopalakrishnan, you're there. You have experience in IgA nephropathy, at least in IRG. You want to say something? And other people from the house also, I think I would welcome suggestions, contributions.
Actually, rather questions to my personal comments. I think all the existing therapies, so-called specific immunosuppressive therapies, which are available at present for IgA nephropathy, they are of absolutely no avail. But for the general supportive therapy, RAS inhibition is starting. Why I say that, if we have a symposium of seminar of experience of all the centers of IgA recurrence post-transplant, it's pretty high. It is an underdiagnosed, underrated problem. The more the duration of follow-up post-transplant, the more is the recurrence rate, as high as 20-30%. A transplant recipient who has been on triple immunosuppression, if that triple immunosuppression is not able to prevent recurrence of IgA nephropathy, how can we expect beneficial impact of the steroid therapy alone in IgA treatment? This is one basic common observation. This is
So with IgA-GM being defined with immunofluorescence presence of a dominant or a co-dominant IgA, it is at least 2 degrees more than the other, being the defining character. Is it right on our part to include patients who have IgA 1+ or C3 2+, 3+ as patients of IgA-GM in our studies?
Today you can answer it.
Again,
the definition being IgA-GM.
yes.
Is 2 plus more. Yeah. Yes,
Doctor, will you first introduce yourself? I'm sorry, I didn't know.
Yeah.
Extremely sorry, sir. So myself is Coordinator Manji. I'm a third-year student, SR student at BHU, sir.
Very good.
So your question is, if the IGA is 1 plus, then how we are going to confirm that it is IGA or not IGA? Or it has a concomitant presence of CT. So whether it is infection-related IGA. One thing Shomita mentioned that K55 is that they are saying the galactose deficient IgA1 is being measured in him, and then pick up that is the specific variety of IgA that you see in IgA disease and not in the IgA related infectious disease. That is one possible way. And the other possible way, which is clinically practice point important, is you may not have IgA1 available with you, but if the other parameters like mesangial deposition of IgA, so mesangial, it also suggests that it is likely to be IgA. You are finding the endocap proliferation, mesangial proliferation, and other components of ACE and T. So it is overall the presentation. The diagnosis is not based on, yes, the main stakeholder is IA, but not only IA. And the clinical presentation of IgA is really variable, as we were mentioning. It can present as MCD, MCD, SSGS. You can have a lot of answers, or you can take it. Any answer you want to try, Somita?
Have a C3 dominant and IgA is +1, by definition it becomes a C3 glomerulopathy, not a IgA nephropathy. That is the definition. If it's IgA +1 and C3 +2 +3, it is, you don't know how to consider IgA. Of course, there is always a question whether it is an infection-related GN or a C3G, but it is not an IgA in that case.
Soumita, Arpita, and Sushina, all three, I would like to ask whether you'll make KM55 mandatory in all IgA biopsies. If so, what is the treatment implications?
Pediatrician's clinic and don't get checked for hypertension. So keeping it mandatory may make us the 20 years patients are reporting in our OPD with high proteinuria and a stake of hypertension that picked up 4 years earlier and pushing us to biopsy. That's why I was talking of longitudinally repeating it. Those patients who will have persistent proteinuria plus minus hematuria, we may pick up them more evidently who are having hypertension, obesity, the epigenetic risk markers for kidney disease too, which may modify our genetic state, and they may be included. That thing is not included in school health screening, and I need more senior people with me to counsel for that whether it can be made mandatory.
Last comment by Dr. Sushina.
Just a clarification, I please don't go home saying that I advocated steroids here. No, I did not. This is an observational cohort study. It's the center's protocol, and it's not a randomized control study to answer the question that was specifically asked. The other thing is, we also did not give steroids for low GFR, but as Dr. Narayan sir mentioned, we do see that T2 lesions do not respond specifically to any kind of immunosuppression. And to corroborate your findings, sir, we've also found anti-GBM antibodies in patients with IgA nephropathy. And the last comment is, I do not have experience of K55 staining in renal biopsy.
Thank you, Dr. Sushina. I think you all agree. We had a wonderful session of IgA nephropathy, and it has raised a lot of questions in our mind, more solutions to be sought, and we thank the organizer. Are we having valedictory function now?
Nothing like hereditary functions. If anyone has any comments, they can pass the comment, or lunch is ready outside. Everyone is invited to have the lunch and go with the sweet memory. If anyone has any comment, then
Yeah,
they
definitely.
can
I
come
think
always. Yeah. Thank you, Chairperson. Thank you, sir,
we,
for
we
making
do,
this session very.
Narayan,
Yeah,
definitely would like to speak something. Like, think our people are there. It's a great opportunity to be here on the foundation day of SGPGI Nephrology Department. I think, sir, as I already mentioned, seeing the progress of the department over all the years and knowing people, Dr. PJK, Dr. Sharma, Amit, Narayan, Nupama, Dr. Madhur, Badoria. So the way you have been working is really very hard. And today's session, the CME doesn't seem to be just a small CME. It seems like you have got people from all over the international meeting. It's a really, really nice. And we enjoyed. I particularly myself, a person who's retired, I've learned so much from this. And thank you for inviting us. Maybe Dr. You want to say something? Okay, Gopal.
Narayan, thank you so much for this holistic, wonderful treat which we had for the past 1.5 days. It was kind of a beautiful occasion, mixed with nostalgia, emotions, and wonderful science too. Always we look upon coming to SGPGA for different purposes, but this event was entirely unique and different. On behalf of all the delegates and faculty of this event, I place on record our gratitude to the organizers and all the past and present faculty. We wish you all a wonderful time.
Thank you very much, sir. Thank you very much. All those who are here, we can have the one group photographs and then we can go all together. And because our all faculty members are also here, so kindly come forward and we can have the group photographs. No?